चलो वेलकम बैक. गुड इवनिंग एवरीवन. होपफुली चाय पी ली, ताज़ा. ओके, all of you fresh. Now definitely we'll be talking about traumas further. थोड़ा सा पेस अप करेंगे यार अभी. ठीक है, shall we? People are joining in still. Okay. Okay, great. Chalo. Now let's talk about further. Tomorrow it won't be there because tomorrow I am having another class. So yeah, well, you might have something else. I'm not sure about that. But day after tomorrow it would be there. 12th, right? Yeah. Now, if I talk about the next one, bacho, it says the question that here we are having a 22-year-old male who comes to us following a road traffic accident. He was referred to us 2 days later. On examination, his GCS of this patient is E2, V3, M2. So the total GCS of this patient will be around 2 plus 3 plus 2, that is around 7. So the total GCS of this patient will be around 7. Please let me know, bacho, that it is a case of mild head injury, moderate head injury, or a severe head injury. The GCS of the patient is around 7 and he had no fractures. There is no visible bleeding. There is no lacerations as such. The blood pressure of this patient is around 180 by 90 millimeters of mercury. Screen. Yeah, just a minute. Got it. Yeah, I know. I'm not writing anything. So very good, all of you. It is actually a case of severe head injury as the GCS of this patient is less than 8. As it is less than equal to 8, therefore it is a case of severe head injury. Now in this patient definitely हो गया क्या connect? Okay. So in this patient definitely now, as you can see, the blood pressure of this patient is very high, 180 by 90 millimeters of mercury. I'll talk about that why it is seen. Then the patient's blood, the heart rate is very low, that is around 52 beats per minute. Okay, so there is hypertension and bradycardia in this patient, which is actually a feature of brain injury. When a patient is actually having some brain injury, there will be raised intracranial pressure. Due to that, the patient might have this Cushing's triad that I'm going to talk about, and that is the reason the patient is having hypertension and bradycardia. Okay, we will talk about that later. Abhi to question pe focus karo. GCS of this patient is not improving. GCS of this patient is not improving, and the NCCT head which was performed has been given below. What is the likely diagnosis? Do you find any problems on the NCCT head of this patient? No, the bone appears fine. There is no fracture as they have also mentioned it. Okay, ventricles look fine. Definitely, though, there is nothing which is very much black or which is very much white. Okay, so there is no opacity. There is no hyperdensity or a hypodensity which is seen. So definitely, the NCCT of this patient also appears to be normal. The NCCT of this patient appears to be normal. Okay, so what is the likely diagnosis in this patient? Anybody can tell me? Okay, so just tell me the likely diagnosis. Till that time, I'll be talking about the brain injuries, the type of brain injuries. There are two types of brain injuries. Okay, the first one is called as a primary brain injury. What do I mean by primary brain injury? That means injury to the brain due to the impact. Okay, तुमने जो मारा उसकी वजह से जो brain में लगी, that is what is called as a primary brain injury. Next is the secondary brain injury. Secondary brain injury is not due to the impact itself. It is actually due to the inflammation which appeared, due to which there was a raised intracranial tension. So due to trauma, there was cerebral edema, and due to that edema, there was a raised intracranial tension. उसकी वजह से जो ब्रेन इंजरी होती है, उसकी वजह से जो न्यूरोलॉजिकल फीचर्स आते हैं, that is what is called as a secondary brain injury. So primary is due to the trauma itself, but secondary is due to the raised ICP, which is secondary to the trauma. ठीक है, so these are the two types of brain injuries. If I talk about the primary brain injuries first, very good all of you. Yes, so if I talk about the primary brain injuries first, primary brain injuries की अगर मैं बात करूं, the mildest form of a primary brain injury बच्चों is known as a concussion. Yes, the mildest form of a primary brain injury is known as the concussion. Okay, it is the mildest form and it has 3 grades. That means initially the patient might only be in confusion. The patient will only be confused. Okay, he is in his senses, but only the patient is confused. Second, the patient might have some loss of memory. That is called as amnesia. Amnesia is nothing but loss of memory. Third important, the patient will be having loss of consciousness. LOC is loss of consciousness. Patient will be unconscious, behosh hoga patient. Okay, so these are the three grades of concussion that we have. Okay, here the NCCT of this patient will be absolutely normal. Yes, in a patient of concussion, as it is a very mild brain injury, it will not be even visible on an NCCT scan. And what is the treatment? Treatment is nothing but conservative management in the patient. What do I mean by this conservative management? Only if the patient is having raised ICP features, we have to treat the patient for raised intracranial tension, not for the concussion itself. ठीक है, concussion से कोई दिक्कत नहीं होती patient में. Usually, okay, it is usually due to the raised ICP, so conservative management should be done in the patient. No surgical management is required for a case of concussion. Next important definitely we got for a contusion. As I've already told you, contusion is nothing but a bleeding inside the brain. Okay, and if there is bleeding inside the brain, it can form collection of blood, and collection of blood is known as a hematoma. So definitely bleeding inside the brain leading to a collection of blood known as hematoma is what is called as a contusion. We have discussed in anterior cranial fossa fracture, there were frontal lobe contusions. In middle cranial fossa fracture, there were temporal lobe contusions. And in posterior cranial fossa fracture, there were occipital lobe contusions. So contusions are nothing but hematomas which are usually formed in the patient. Okay? Treatment, as I've told you, they resolve on their own. Nothing is required for them. They are very small and therefore they resolve on their own. अपने आप ठीक हो जाते हैं. Nothing is required. Rarely, if they are very large in size, then only we might require an intervention. Okay, that is a surgical intervention will be required. Only if they are very large in size. And the surgical intervention is the same. It is nothing else but craniotomy which should be done. Okay, neurosurgery has to be done. Now, the severe most form of a primary brain injury, when there is injury to the brain actually, is this one. Very good. All of you are right. The likely diagnosis in this condition is a DAI. And what do I mean by a DAI? DAI is nothing but diffuse axonal injury. Okay, DAI is nothing but a diffuse axonal injury. Now we know that just like our body is made up of cells, our kidney is made up of nephrons, just like that our brain is made up of multiple neurons, and the neurons usually has two parts. This is what is the axon, this is what is the cell body, and this is what is the axon of the neuron. ठीक है, तो ये जो axons है, अगर ये कट जाते तो okay, so if these axons which are there, if these axons are stretched, they are injured, they are damaged. That is what is called as diffuse axonal injury. Now why it is called as diffuse? Because it is not seen in particular part of the brain, bache, it is rather seen in the whole brain. Okay, therefore it is called as a diffuse axonal injury. Where actually it is seen? It is actually seen over here. Can you see? This is the junction of the gray matter and white matter. Okay, so definitely if I talk about the junction of the gray matter and white matter, definitely, okay, at the junction of the gray matter and white matter over here, we are going to have these axons. Definitely, and these axons are going to be injured. Okay, these axons which are there at the gray matter white matter junction, I'm just showing it to you just for representation. Exactly ऐसे नहीं होते वो. ठीक है? So these axons which are there, they will be stretched. Yes, there will be a shearing force, tearing force. Shearing का मतलब tearing. Okay, खींचने वाला, तोड़ने वाला. There is a shearing force or a tearing force at this gray matter white matter junction, which is going to cause stretching or which is going to cause injury of these axons. ठीक है? And multiple axons will be damaged. That is what is called as a diffuse axonal injury. No issues with this. So that has to be remembered, बच्चों. So this diffuse axonal injury, you have to remember, it is due to, it is first of all, write down, it is the most severe form. It is nothing but the most severe form of primary brain injury. It is the most severe form of primary brain injury that you have to remember. Okay? It is due to a shearing force, or you can write even a tearing force. It is due to a shearing force on the axons. It is due to shearing force on the axons at gray matter white matter junction. At gray and white matter junction. Okay, it is due to shearing force on the axons at gray and white matter junction. Okay, so that has to be remembered. No issues with this, anybody, bacho? Important is now these axons which are stretched at the gray matter white matter junction, they definitely are stretched, they are injured, therefore they will have small bleeding over there. Okay, they will have small bleeding spots over there, but those bleeding spots cannot be picked up with the help of a normal CT. CT पे देख सकते हैं, but if they are larger in size, and that is very rare that a diffuse axonal injury can show any finding on a NCCT head. Therefore, on NCCT head, no findings will be seen in the patient. NCCT head in most or majority of the patients of DAI, it appears absolutely normal. Okay? So you have to remember definitely here the patient's NCCT is going to be absolutely normal in most of the cases. I'm saying most of them. Okay? And the patient will have a very low GCS. The patient is going to have a very low GCS. That means always suggest you of a severe head injury less than equal to 8 always. The patient is going to have a very low GCS, or they can even mention the patient's GCS is falling. The patient's GCS is falling. So there will be a falling GCS, or the third term that they will mention that the patient's GCS is not improving. Okay, so if NCCT is normal, and even though if the MCCT is normal, the patient is having a low GCS, falling GCS, or a non improving GCS, that is a classical case of DAI usually. Okay, that is a classical case of DAI. Okay, so you have to remember that. Depending on the site of injury, the patient is going to have a lot of features. The patient will have paralysis of the limbs. The patient will not be able to speak, aphasia. The patient will not be able to eat properly, dysphagia, dysarthria. All of these features will be seen. Multiple features are seen. Okay. Cranial nerve injuries can also be occurring in this patient. Important now, in this patient of diffuse axonal injury, what is the investigation of choice then? If everything appears to be normal, what is the investigation of choice? It is a T2 weighted MRI. You have to remember it is a T2 weighted MRI, which is the investigation of choice. Now MRI is nothing but a magnetic resonance imaging. Important, why T2 weighted? There is a T1 weighted MRI and a T2 weighted MRI. T2 weighted MRI में ये याद रखना दो W आएंगे, मतलब water appears white. Okay, any kind of fluid, any kind of water will appear white on a T2 weighted MRI. And here what we want to see? Here we want to see the bleeding, and blood is also a fluid. Therefore we want to see the bleeding. Therefore we have to do a T2 weighted MRI. On this T2 weighted MRI, can you see at the gray matter white matter junction, we can see these small bleeding spots, and these are nothing but the punctate hemorrhages. Okay, so you have to remember these will be called as the punctate hemorrhages. Sound not audible? Is it not audible for everyone? Is it not audible to anyone? Is it not audible to anyone? So it's normal. Please check from your side. The connection from your side might be having some issues. Okay, so please check it. So investigation of choice, bache, it is a T2 weighted MRI on which we are able to see a punctate hemorrhages. We are able to see punctate hemorrhages. This has been a previous year question that first it has been asked for diagnosis. Diagnosis has been asked multiple number of times. It is diffuse axonal injury, and once they have also asked you about the investigation of choice, you know now it is a T2 weighted MRI on which definitely you will be able to see the classical punctate hemorrhages. Important is treatment here. We will just go for a conservative management. Reason is over here we cannot repair these axons. Each and every axon cannot be repaired over here, and most important, this condition has a very poor prognosis, very poor outcome. A lot of patients are going to die usually. A very poor prognosis will be there. You might be knowing definitely the most famous F1 racer, Michael Schumacher. Michael Schumacher actually met with a severe accident, and he also sustained this diffuse axonal injury. Okay, so he is also having the same diffuse axonal injury, and therefore the outcome is very poor for this condition. Okay, so no issues with this anybody. These punctate hemorrhages are also seen at the gray matter white matter junction, that you have to remember. Now let's talk about the secondary hemorrhages, bacho. If I talk about the secondary brain injuries, if I talk about the secondary brain injuries, I told you secondary brain injuries are not due to the trauma. It is actually due to the raised intracranial pressure or raised intracranial tension in the patient. If there is a raised intracranial tension in the patient, क्यों होता है? Because as I've told you, see, the trauma which is there, बच्चे, trauma which is there, it is going to cause inflammation. Okay, any kind of infection, any kind of trauma can cause inflammation, and that inflammation has a one important cardinal sign, and that is edema. So there will be definitely leakage of fluid outside the blood vessel causing edema. There will be cerebral edema, and if there is cerebral edema, the patient will have increased intracranial pressure, due to which the patient is going to have all these features. Now, it is not only due to edema, sometimes it can also be due to hemorrhage. Due to this edema, due to this hemorrhage, the patient is having an increased intracranial tension. And due to this, all of the problems that the patient is going to face. So, secondary brain injuries are usually due to either the cerebral edema or it is due to the hemorrhage that the patient is going to have, due to which the patient will have raised intracranial tension. Now, whenever the patient has raised intracranial tension, patient will start having immediately headache. सबसे पहले क्या होगा पेशेंट में, डेफिनेटली द पेशेंट विल हैव हेडेक, क्योंकि प्रेशर बढ़ गया अंदर का. ओके, next important is, apart from headache, definitely whenever the pressure rises, the patient can feel nauseated and the patient can have vomiting also. Yes, due to raised ICP, the patient can even have vomiting. Definitely the patient can have blurring of vision. Yes, blurring of vision can also occur whenever there is raised ICT in the patient. Okay, there will be blurring of vision as well. So headache, vomiting, blurring of vision are the common features which can occur due to raised intracranial tension in the patient. As well as in a case of raised ICT, there is a classical triad which is seen, and this has to be remembered. This is known as the Cushing's triad. This Cushing's triad is important to be remembered. The mnemonic to remember this Cushing's triad, bachcho, there are three important features which are going to happen. They are BHC. There are three important features which are going to happen in a patient of raised ICP, where B goes for what? B goes for bradycardia. B is going for bradycardia in the patient. H is going for what? H is going for hypertension in the patient. And C is going for what? C actually goes for irregular respiration. Okay, there is an irregular respiration which is going to occur in the patient, and that irregular respiration is known as a Cheney-Stokes breathing. That irregular respiration is known as a Cheney-Stokes breathing or a Cheney-Stokes respiration. Okay, so these are the three classical features in a patient of raised ICT, and they are classically called as the Cushing's triad. Okay, so bradycardia, hypertension, and Cheney-Stokes breathing or respiration, okay, are the classical three features of raised ICT or Cushing's triad in a patient. Now important is, if a patient is having brain injury or the patient is having problems due to raised ICT, what is the main aim of the treatment? You have to remember the main aim of the treatment is what? Two things we have to do. First, we have to maintain the CPP. What is CPP? I'll tell you. We have to maintain the CPP, that is cerebral perfusion pressure. What is that? It is nothing but the amount of blood flow reaching the brain. Yes, the amount of blood flow to the brain is what is called as CPP, cerebral perfusion pressure. We have to maintain this CPP more than equal to 60 millimeters of mercury. The first aim of our treatment is to maintain the CPP more than equal to 60 millimeters of mercury. And second, we have to bring down the ICT, or we have to bring down the intracranial pressure to less than, 20 millimeters of mercury. We have to bring down the ICP to less than 20 millimeters of mercury, definitely. Okay? So these are the two important features that we have to do in the treatment of the patient. Now, definitely, bachcho, what is a normal ICP? You will be asking me. So normal ICP, yaad rakh lena, it is nothing but 5 to 15 millimeters of mercury. The normal ICP, which is that, it is between 5 to 15 millimeters of mercury. But in a case of trauma, usually in a case of raised ICT, at least our aim is to bring down the ICT to less than 15 millimeters of mercury. Raised ICT kab bola jata hai? When the pressure is more than 25 millimeters of mercury, that is a raised ICT. So therefore, at least our aim is to bring it down to less than 20. Okay, got it? So that is the important funda that you have to remember. Important is now how we are going to bring down the ICT of the patient and how we are going to maintain the cerebral perfusion pressure of the patient. इसके लिए एक formula समझ लो, easy हो जाएगा, बहुत आसान हो जाएगा. So CPP is nothing but the cerebral perfusion pressure. Perfusion is the blood flow. So cerebral perfusion pressure is nothing but the blood flow to the brain. It is nothing but the blood flow to the brain. Second, CPP is equal to MAP minus ICP. What is MAP? MAP is nothing but the mean arterial pressure. MAP is nothing but the mean arterial pressure, the pressure inside our blood vessels, you can remember. Okay, it is nothing but the BP, you can say. Okay, it is the mean arterial pressure minus the ICP of the patient. Okay, so that is what is your CPP. Now problem is what? Here the ICP of the patient is increasing. Here the ICP of the patient is increasing. That is the reason why, and the MAP is normal. Okay, here the ICP of the patient is increasing and the MAP is normal. Therefore, what will happen to the CPP or the cerebral perfusion pressure? The cerebral perfusion pressure or the blood flow to the brain is going to decrease, and that is harmful. So, what our body tries to do is, bache, our body tries to increase the mean arterial pressure. Yes, as our body tries to increase the mean arterial pressure, can you see? As our body is also trying to increase the mean arterial pressure, therefore, our cerebral perfusion pressure will be maintained at a normal range. Therefore, our cerebral perfusion pressure can be maintained at a normal range. Okay, this is what is a compensatory mechanism of our body. This is what is a compensatory mechanism of the body. No issues with this, anybody, bacho? That is important. So, if you want to maintain the cerebral perfusion pressure, Okay, definitely for that purpose your mean arterial pressure should increase, or otherwise you have to decrease your intracranial pressure. Either you decrease your ICP or you increase your MAP. There are two methods by which you can maintain your cerebral perfusion pressure. Because if blood flow to the brain decreases, then it is going to be problematic. Okay, so now what are the management techniques that we are going to do? So you have to remember, okay, first management के लिए we have to give adequate oxygenation to the patient. Yes, we have to give adequate amount of oxygen to the patient. So if there is enough amount of oxygen which is available, definitely the cells or the organs are not going to suffer from hypoxia. ठीक है, so that's the important thing. So, and there will not be any kind of acidosis in the patient. So first, definitely there will be adequate oxygenation should be given to the patient. Second, IV mannitol should be given to the patient. IV mannitol which is there, बच्चों, it is known as osmotherapy. IV mannitol which is there, if we give to the patient to decrease the intracranial pressure, that is what is called as osmotherapy. Why? Because mannitol, we know it is an osmotic diuretic. So what it does actually, जब हम mannitol देते हैं, what is mannitol? Mannitol is nothing but sugar. Yes, mannitol is just sugar. ठीक है? And definitely we know if we give mannitol to the patient, definitely it is going to attract a lot of water, because the plasma will become more concentrated due to the sugar, and therefore it is going to attract more water. So as more water is attracted inside the vessel, okay, therefore definitely the edema is going to decrease. As more water is coming inside the vessel, therefore the edema which is there, it is going to decrease. And as the cerebral edema decreases, definitely the patient's intracranial pressure is also going to decrease. That is one of the things that we can do over here. Okay. Apart from that, definitely we can even go for a ventriculostomy. Now what is a ventriculostomy? Definitely, please remember, ventriculostomy is nothing but actually inserting CSF drains. Yes, we can insert a drain for the CSF inside the ventricles of the patient. Okay, inside the ventricles of the brain, we are going to insert a CSF drain, so that definitely if whenever the pressure rises, whenever there is excess amount of CSF, it will be drained out by this ventriculostomy, okay, or via these drains which are there. Okay, they are fixed, they are not coming outside. Okay, they are fixed over there. So ventriculostomy which is there, it is nothing but inserting CSF drains which are going to decrease the intracranial pressure. Whenever the pressure increases, these drains are immediately going to sense that, and they are going to drain the CSF, so that the pressure will be again brought back to normal. Okay, next important बच्चों, prophylactic antiepileptics, ये plus minus लिख लेना भी, because Bailey now says there is not a rule as such, but only if the patient is having seizures or convulsion like episodes, that is the time we are going to give prophylactic antiepileptics. ये plus minus लिख लो. Previously we used to give prophylactic antiepileptics, matlab even if a patient is not having any kind of seizures or convulsions, just to prevent any kind of seizures, we used to give prophylactic antiepileptics. But abhi, only if the patient has seizures or convulsions, we usually give this antiepileptics to the patient. Okay? In clinical practice, we don't do like that. In clinical practice, aaj bhi, even if the patient is not having seizures, we give antiepileptics to the patient. Okay? Next importance is hyperventilation. Yes, controlled hyperventilation is more important. Okay, controlled hyperventilation definitely can also help in reducing the cerebral edema, reducing the intracranial pressure. So these are the few techniques with the help of which definitely we are going to have what? We are going to manage a patient of secondary brain injury, that is a raised ICP. Now, which fluid should be avoided in a patient? So you have to remember the fluids. This was a previous year question. Which fluid should be avoided in a patient of brain injury or a patient of raised ICT? So you have to remember, any patient of head injury comes to you. Any patient of head injury comes to you. Please avoid hypotonic fluids. What do I mean by hypotonic fluids? See, the fluids which are having same concentration as that of your plasma. जो plasma का वैसा ही concentration होगा, that is called as isotonic fluid. The fluid which has more concentration than your plasma is called as a hypertonic fluid. Okay, more concentration than plasma is your hypertonic fluid. And the fluid which has less concentration as compared to the plasma, that is called as a hypotonic fluid. Important is, what is the isotonic fluids? Same concentration as plasma. It is your normal saline and ringer lactate. Normal saline and ringer lactate which are there, they are isotonic fluids. They have similar concentration as that of the plasma. Whereas what is a hypertonic fluid? More concentration. It is the 3% hypertonic saline. Okay, so you have to remember that 3% hypertonic saline which is there, it can also be used. It can also be used in the treatment of the patient. Okay, 3% hypertonic saline can also be used in the treatment of the patient. Why? Again, on the same mechanism like mannitol. Here we are giving more salt. Over there we were giving more sugar. Over here we are giving more salt, and salt contains sodium chloride. So as we are giving more salt, there is more sodium inside the blood vessel, and we know that sodium is a friend of water. It is going to attract water, and therefore by looking at the sodium, more and more water is going to come inside the blood vessel, and that is how the edema is going to decrease. So therefore 3% hypertonic saline definitely can be used for the treatment of raised ICT. But on the other hand, if we give hypotonic fluid, बच्चे, if we give hypotonic fluid, what is going to happen? See, hypotonic अगर fluid दिया, मतलब the concentration of this fluid is very low. Okay, concentration of this fluid is very low. ज़्यादा concentration कहाँ है? More concentration is outside the blood vessel. More concentration is outside the blood vessel. And due to diffusion, we know कहाँ से कहाँ तक जाता है? Low concentration से high concentration. Fluid is going to go from low concentration to high concentration. So therefore, as there is high concentration outside the vessel, as there is high concentration outside the blood vessel, all this fluid is going to leak out from the vessel. All this fluid is going to leak out from the vessel. And now if the fluid is going to leak out from the vessel, it will collect inside the it will collect between the cells definitely, and it is rather going to increase the cerebral edema. So yaad rakhna, if we give hypotonic fluid, that means the fluid which is having less concentration, okay, it is going to leak out from the vessel and it is going to cause more cerebral edema. It will rather increase the intracranial pressure. Therefore, any kind of hypotonic fluids are absolutely contraindicated in a patient of head injury. Okay, any type of hypotonic fluids are absolutely contraindicated in a patient of raised ICT, okay, or any kind of head injury. What are these hypotonic fluids? So you have to remember 5% dextrose. Okay, the best example is a 5% dextrose, 10% dextrose. Okay, so definitely D5, D10, D25. These are the best examples of hypotonic fluids, bache. These are hypotonic fluids. So they are absolutely contraindicated or avoided in a patient of head injury or a patient of raised ICT. That has been a previous year question. No issues with this, anybody? Chalo. Trauma is usually one of the reasons. It can be infection also. Raised ICP can occur due to infection also. It can occur due to uncontrolled hypertension also. It can occur due to stroke also. There are multiple reasons to it. We are talking about trauma, no? In medicine, you will be talking about the other reasons for it. Okay? Now, if I talk about the facial fractures, bacho. If I talk about the facial trauma now. If I talk about facial fractures now, facial fractures can be of two types. Either it can be upper face fractures. Okay, either it can be the upper face fractures or it can be the lower face fractures. The upper face fracture, the upper face matlab ye wala part. Okay, this is nothing but your maxillary bone, right? So upper face fractures matlab they are talking about the maxillary fractures mainly, right? So upper face fractures matlab they are mainly talking about the maxillary fractures. Okay, whereas lower face fractures matlab they are more commonly talking about the lower part of the face, and this is which bone? Mandible. So therefore lower face fractures matlab they are mainly talking about the mandibular fractures. They are mainly talking about the mandibular fractures. Now we know that this maxillary fractures which are there, they are actually classified according to the La Forte classification. So what is the classification used for the maxillary fractures? So this is nothing but the classification of the upper face or the maxillary fractures. So you have to remember the maxillary fractures are classified according to the La Forte classification, and according to this, the type 1 La Forte which is there, can you see over here? The fracture line travels via the palate, and as the fracture line travels via the palate, there is a horizontal fracture over here. So type 1 La Forte is known as a transverse fracture. Type 1 La Forte is known as a transverse fracture, or we can call it as the horizontal fracture. We can call it as the transverse or the horizontal fracture. Next one, type 2 La Forte which is there. The type 2 La Forte which is there, here the fracture line travels via the root of the nose. Ye jo root hai, the fracture line passes via the root of the nose, okay, and therefore this fracture looks like triangle now. Therefore type 2 La Forte fracture is known as a pyramidal fracture because it looks like a triangle or a pyramid. Therefore type 2 La Forte is known as a pyramidal fracture. Type 3 La Forte bacho, type 3 La Forte definitely, as you can see, the type 3 La Forte, here the fracture line passes by the orbits as well as the root of the nose. Here the fracture line passes by the orbit and the root of the nose, and as it passes by the orbits and the root of the nose, okay, the connection between the face and the cranial cavity, is lost. Okay, there is a craniofacial disjunction which is there. So therefore type 3 La Forte which is there, bacho, you have to remember, okay, type 3 La Forte which is there, it is known as a craniofacial disjunction. It is known as craniofacial disjunction. No issues with this, anybody? Okay, it is known as craniofacial disjunction. Okay. Important is, can anybody tell me that in which types of La Forte the patient is going to suffer from CSF rhinorrhea? We know that the cribriform plate, when it gets fractured, definitely then there is leakage of CSF from the nodes, and that is what is called as CSF rhinorrhea. Okay, in which types of La Forte there will be CSF rhinorrhea in the patient? Please tell me that. In which type of La Forte there will be CSF? Very good. It is type 2 and type 3. Very good. So because we know in type 2 and type 3, in both the conditions, the fracture is actually passing via the root of the nose, and we know that the root of the nose is mainly formed by the ethmoid bone. So there will be fracture of the cribriform plate as well. So in type 2 and type 3, not in type 1. Type 1 में तो कोई मतलब ही नहीं है ना वहां तक. This is the cribriform plate out here. Okay. Type 1 में तो कभी नहीं दिखेगा. You have to remember type 2 and type 3 will present to us with CSF rhinorrhea. Type 2 and type 3 will present to us with CSF rhinorrhea. That has to be remembered. Okay? The management can be either conservative or it can be surgical. Most of the times it is a conservative management that we have to go for a facial fracture. Next important is this one, bacho. Now if I talk about the mandibular fracture, what is the most common site of the mandible which gets fractured? This is a previous year question. The most common site of a mandible which gets fractured, you have to remember. The most common site of a mandible which gets fracture, it is this one. ये क्या होता है? उसकी neck, गर्दन उसकी, okay? The neck of the mandible or the condyle of the mandible is the most common site of the mandible to undergo fracture. Yes. So you have to remember the most common site of a mandibular fracture is actually the condyle of the mandible followed by the angle of mandible. The most common site of a mandibular fracture is actually the condyle of the mandible followed by the angle of the mandible. No issues with this. But if they ask you which is a dangerous fracture of the mandible, so you have to remember the dangerous fracture of a mandible. Okay, dangerous fracture of a mandible is actually this butterfly fracture. The one which is shown in the CT scan below. This is the butterfly fracture, bacho, and this is considered as the dangerous fracture of the mandible. This is considered as the dangerous fracture of the mandible. Why this one is considered as the dangerous fracture of mandible? There is a reason for it. Can you see? Here there is a fracture of the mandible out here. Here there is a fracture of mandible. And here we have actually a muscle which is attached from inside. और कौन सी muscle attached होती है यहाँ पे? The muscle which is attached at this point is known as the genioglossus muscle. And all of us are quite aware that this genioglossus muscle is also known as safety muscle of tongue. Why? Because this fan-shaped muscle which is there, it is actually going to hold the tongue. Okay, this fan-shaped muscle which is there now, it is going to hold the tongue. Okay, it is going to hold the tongue. Therefore, the tongue will not fall back. The tongue is not going to fall back. But if there is a fracture in the mandible, okay, at this side, definitely the genioglossus muscle will be released. And as the genioglossus muscle gets released, now the tongue can easily fall back. Now the tongue will get free now. Therefore, the tongue can easily fall back. And as the tongue falls back, bacho, it is going to block the airway. And as the airway gets blocked, the patient will die of respiratory arrest. Okay, the patient can die due to respiratory arrest. That is the reason why you have to remember this is called as a dangerous fracture of the mandible. Dangerous fracture of mandible is over here, okay, at the genial tubercle. So the dangerous fracture of the mandible is known as a butterfly fracture. I'll write it properly. So this dangerous fracture of the mandible is known as the butterfly fracture. And why it is considered dangerous? Okay, it is considered dangerous because there is release of, okay, it causes release of genioglossus muscle, which is known as the safety muscle of tongue, right? There is release of genioglossus muscle, which is the safety muscle of tongue. Due to that reason, definitely the tongue falls back and blocks the airway. Due to that reason, the tongue falls back and blocks the airway. Okay, the tongue falls back and blocks the airway. And due to that reason, definitely the patient is going to have respiratory arrest. Due to that reason, the patient can have respiratory arrest or there will be severe respiratory distress. That is the reason why this is considered as the most dangerous fracture of your mandible. This is considered as the most dangerous fracture of the mandible. Important is, what is the treatment in a case of mandibular fracture? The treatment in a case of mandibular fracture is known as the interdental wiring. Either we can go for an interdental wiring or we can go for ORF. What is ORF? Open reduction and internal fixation. The treatment for a mandibular fracture, you have to remember, bacho, it is nothing but interdental wiring we have to do, or we can go for an open reduction and internal fixation. Okay? Next is this, you might have studied in ENT or in Octa as well. What is this fracture? Classical Sarkari question of your exam. This CT comes in your examination, and can you see this sign over here? Normal is this one. कोई दिख रहा है ऑर्बिट से कुछ भी नीचे आते हुए? नहीं. But in this one, the one that I've highlighted, the one that I've circled over here. Definitely, can you see? Definitely the soft tissues of the orbit. The soft tissues of the orbit are coming down inside the maxillary sinus. And the soft tissues of orbit, why they are coming down inside the maxillary sinus? Because the floor of the orbit has been fractured. The floor of the orbit has been fractured. And this is a classical case of blowout orbital fracture. This is a classical case of blowout orbital fracture, bachcho, you have to remember. And this blowout orbital fracture, if I talk about, here, it is due to which kind of a trauma? It is due to a blunt trauma. You have to remember. The blowout orbital fracture is mainly due to a blunt trauma. Okay. And which kind of blunt trauma? They will classically mention about a tennis ball injury. They are going to classically mention about a tennis ball injury. Yes, there was a tennis ball injury to the orbit of the patient, due to which there is a fracture, and that is a blowout orbital fracture. You have to remember that the most weakest wall of the orbit is actually the medial wall. Weakest wall of the orbit is the medial wall. But can you see the medial wall is protected by the nose? Yes. And as the medial wall is protected by the nose, it is not commonly fractured. So which is the most commonly fractured wall then? The most commonly fractured wall is the floor, because it is most prominent. Okay, so the most prominent wall or the most commonly fractured wall is definitely the floor. So most common wall which is fractured, the most common wall which is fractured is actually the floor of the orbit, followed by the medial wall. Okay, so the most common wall fractured is the floor of the orbit, followed by the medial wall. That has to be remembered. कोई दिक्कत नहीं है यहाँ पे. Now definitely investigation will be done by NCCT scan, and NCCT face is going to show us this kind of a feature. As you can see in the image also, the soft tissues of the orbit are going to come down inside the maxillary sinus, and they look like a teardrop. आंसू की बूंद जैसा लग रहा है ना? So therefore this NCCT head is going to show us a classical teardrop sign. It is going to show us a classical teardrop sign, and this has been a previous year question. This has been a previous year question. No, this is not the Holman-Miller sign. Holman-Miller sign is seen in cases of angiofibroma. That is different. Okay. So this is the teardrop sign which you've seen. Treatment in most of the conditions, you have to remember, it is conservative. Yes, if it is undisplaced fracture, na, in most of the conditions, it will be a conservative management itself. Okay, if it is undisplaced fracture. Only if it is a displaced fracture, we might need to go for a surgical management. Okay? Only if the muscles are getting entrapped over here, or if there is definitely a displaced fracture, then we can go for a surgical management. Okay? That's important. Now let's talk about neck trauma. Neck trauma is also short, just like face. Okay? Neck trauma mein you just have to remember the 3 zones and what is the mode of management that we use for injury to these 3 zones. Okay? बस इतना याद रखना होता है. Because they ask you कि if there is injury to the zone 2 of the neck, what is the management? Whether it is conservative, whether it is surgical, whether it is angioembolization, what it is. Okay? So let's talk about that now. Okay? So please remember, NCCT is nothing but non-contrast CT scan. That's one and the same thing. Na? It is a CT scan only. So NCCT is nothing but non-contrast CT scan. CT can be of 2 types, NCCT or a CECT, contrast enhanced or a non-contrast. If I talk about neck trauma, bachcho, definitely, if I talk about a neck trauma, okay, if you're not using a contrast, the plain CT is what is called as NCCT. ठीक है? So normal CT जो होते हैं वो सब NCCTs होते हैं फिर. बस contrast use करोगे तो CT हो जाता है वो. If I talk about a neck trauma, definitely you have to remember about the 3 zones of the neck. As you can see, the first zone of the neck goes from this is what is the sternal notch or the suprasternal notch, whatever you call it. Okay? This is the sternal notch. From the sternal notch till the cricoid cartilage. From the sternal notch till the cricoid cartilage, that is considered as a zone 1 of neck. That is considered as a zone 1 of neck. Then from the cricoid cartilage till the angle of mandible. From the cricoid cartilage till the angle of mandible, that is considered as the zone 2 of neck. And from the angle of mandible till the base of skull. From the angle of mandible till the base of skull, that is considered as the zone 3 of neck. Okay? You have to remember that the zone 1 which is there, it contains your major vessels. Zone 1 jo hota hai bachche, it contains major vessels like superior vena cava, definitely. Apart from that, the common carotid artery, the internal carotid artery, the external carotid artery, all these major vessels which are there, definitely they will be present inside. Okay? So you have to remember all of these are definitely present inside the zone 1 of the neck itself. Okay? Whereas zone 2 which is there, can you see the zone 2 is a larger area? This zone 2 is the most commonly exposed area. This zone 2 which is there now, it is the most exposed area of the neck. As it is the most exposed area of the neck, highest chances of injury or highest chances of trauma will be to the zone 2 of the neck. So most commonly injured zone of the neck has to be the zone 2. Okay? And zone 3 again contains major vessels. Okay, zone 3 will again contain the sigmoid sinus, the internal jugular vein, as well as all of that. Important is zone 3 में भी injury हो सकती है, but there are less chances of bleeding. Zone 1 has a maximum chances of excessive bleeding. ठीक है? So now, if I talk about the zone 1, you have to remember zone 1 is from suprasternal notch till the cricoid cartilage, and vital structures are present over here. Which vital structure? Vital का मतलब important. Vital structures which are present over here are nothing but the major vessels. Okay, vital structures which are present over here are nothing but the major vessels. Then zone 2 which is there. Zone 2 is nothing but from cricoid cartilage till the angle of mandible. It is the most exposed area of neck, and as it is the most exposed area of neck, therefore it is the most common zone for injury. It is the most common or the most prone area for injury. Most common or the most prone area of injury. Okay, most common site or the most prone area for injury is definitely the zone 2. No issues with this. Zone 3 which is there, bacho, you have to remember, zone 3 extends from the angle of mandible till the base of skull, and here the major vessels are going to be present. Okay, here also the major vessels are going to be present. Important is, if I talk about the management of the patient, you have to remember, okay, so zone 2 patients ki agar main baat karu, zone 2 patients, the most common ones which are going to present to us. Zone 2 patients, usually they are majority of the time stable. They are hemodynamically stable. Matlab these patients will not have much of bleeding, and these patients majority of the times will be hemodynamically stable. Matlab these patients will not be in shock. Okay? So you have to remember that zone 2 के majority जो patients होते हैं बच्चे, they are hemodynamically stable. Majority of the patients of zone 2 are hemodynamically stable. And if they are hemodynamically stable, do we need to go for any surgical management as such? No. Here we don't need to go for any surgical management. Here we can just go for a conservative management. Here we can just go for a conservative management of the patient. Okay. Whereas if I talk about the unstable patient की अगर मैं बात करूँ, hemodynamically unstable, I'm saying that means the patient is having a lot of bleeding, and due to that the patient is going into shock. If the patient is having a lot of bleeding and the patient is in shock, or the patient is hemodynamically unstable, I have to go for a surgical exploration. Yes, I have to open the neck of the patient and I have to explore it surgically to see what is the site of bleeding, which vessels are bleeding, and then I have to actually ligate those vessels. I have to repair those vessels. Okay? So zone 2 के अगर unstable patient होगा, then only we will go for a surgical exploration. Now zone 1 and zone 3. Zone 1 and zone 3 में common क्या था? In zone 1 and zone 3 definitely major vessels were present, and due to that there will be more bleeding. But important is, as these are vessels, definitely can we go for an angioembolization? Yes, we can just inject a substance in these vessels which can go and block the bleeding site. This is what is called as an embolizing substance. If we inject a substance inside the vessel which is going to block the bleeding site, definitely the bleeding is going to decrease and the patient's condition is going to improve. Okay? Here we don't even require to open up the patient completely. Okay? This is angioembolization, bachche. You have to remember that for zone 1 and zone 3 patients, you have to go for angioembolization. You have to go for the angioembolization. Okay? If angioembolization fails, then definitely, you have to go for a surgical exploration. That means even after doing angioembolization, the patient's blood pressure is falling or the patient is going into shock. In that condition, definitely you have to go for a surgical exploration of the patient. Then you have to go for a surgical exploration. कोई दिक्कत नहीं है यहाँ पे. Okay, got it? So these are the three zones that you have to remember in the neck, and according to the zone, definitely you have to manage the patient. Now we are done with this. So let's start with the thoracic trauma, bachcho. If I start with the thoracic trauma, you have to remember definitely in thoracic trauma, shall I? Okay. Okay. बच्चे CT is nothing else but NCCT itself ना. अगर CT में तुम कॉन्ट्रास्ट यूज नहीं करोगे, उसी CT स्कैन को क्या बोला जाएगा? नॉन कॉन्ट्रास्ट CT स्कैन. ओके, दैट इज व्हाट इज द नॉन कॉन्ट्रास्ट CT स्कैन. ओके, व्हाट वाज द परसेंटेज? इट वाज द अमाउंट, मतलब कितने टाइप के फ्रैक्चर जो होते हैं, प्लीज रिमेंबर, कितने टाइप के फ्रैक्चर्स, टाइप 1 होते हैं, टाइप 2 होते हैं, टाइप 3 होते हैं. आउट ऑफ द टोटल मैक्सिलरी फ्रैक्चर्स कितने टाइप 1, कितने टाइप 2 और कितने टाइप 3 होते हैं? दैट इज नॉट वेरी मच इंपॉर्टेंट फॉर यू, फॉरगेट दैट. Okay, got it. Chalo, now let's talk about the thoracic trauma. If I talk about the thoracic trauma, bachcho, now in thoracic trauma or in chest trauma, definitely what is going to be the first investigation? Okay, what is going to be the first investigation in a case of thoracic trauma? Can anybody tell me? If a patient comes to you with a chest trauma, definitely chest trauma ke baad, the first investigation that we'll do is definitely a chest x-ray itself. Yes, so the first investigation in a patient of thoracic or a chest trauma is going to be a chest x-ray. Important is you have to remember that the chest x-ray which is taken, the chest x-ray is mainly taken in the PA view. What is PA view? Postero-anterior view. It is mainly taken in the PA view, but if the patient is not able to get up, PA view ke liye the patient has to stand up. Okay, but if it is not possible that the patient could not stand, if he is unconscious or the patient is not able to stand due to fracture or any of the reasons of trauma, then definitely we can even suffice or even we can do a AP view. Antero-posterior view is also normal. Okay, commonly PA is better view, okay, because the whole lung will be covered properly. But if not possible, then you can even do a AP view. For trauma patients, usually it is the AP view only because they are not able to get up. And next important is we can take the chest x-ray in the expiration phase or in the inspiration phase. Usually x-ray is taken in the inspiration phase because when the patient inspires, definitely the lung is fully expanded and we can actually examine the lung properly on the chest x-ray. But in only one condition, the chest x-ray is taken in the expiratory phase, and that is what is known as the pneumothorax. Okay, only one exception. No, normally, as I've told you, it is taken in the inspiration phase. Only one exception that you have to remember. This was a previous year question, that chest x-ray is taken in expiratory phase in. So chest x-ray is only taken in expiratory phase in a case of pneumothorax, when there is a lot of air inside the pleural cavity and the lung is compressed from outside. Only in that case, definitely we will take it in the expiratory view. Now important is first investigation is always a chest x-ray. But what is the emergency investigation? Emergency investigation after a chest x-ray, definitely we have to look for any blood collection. And to look for blood is nothing but a fluid. फ्लूइड का दोस्त कौन सा रेडियोलॉजिकल इन्वेस्टिगेशन होता है बच्चों? फ्लूइड का दोस्त होता है अल्ट्रासाउंड. Therefore we have to do a rapid ultrasound, but that rapid ultrasound which is done in a case of trauma, for the abdomen it is known as fast. But agar if we also do thorax ke liye, then it is called as a E-fast or an extended fast. I'll talk about fast, don't worry. But here you just remember that the emergency investigation which is done for a chest trauma or a thoracic trauma, it is E-fast or an extended fast. Okay, it is a E-fast or an extended fast. ठीक है? Pneumothorax, याद रखना, usually the chest x-ray is taken in the inspiratory phase of respiration. Only for pneumothorax, it is taken in the expiratory phase of respiration. That is what I said. ठीक है? The most commonly fractured part or the most commonly injured part of your chest which is there बच्चों, क्या है सबसे आगे chest में? Ribs. Okay, and the ribs are weak also थोड़ा. Okay, so definitely the most commonly part which is fractured or which is injured in a chest is definitely going to be the ribs. Okay, so the most common fractured part, most commonly injured part is nothing but the ribs. These ribs are going to undergo fracture. Important is if they ask you which are the most common ribs which will undergo fracture. So you have to remember the 4th to the 9th ribs. Okay, 4th to the 9th ribs are the most prone for fracture. Kyun? Because they are exposed, na? 4th, 5th, 6th. See, this is the 4th, 5th, 6th, 7th, 8th, 9th. So these ribs which are there, 4th to the 9th ribs, definitely these are exposed to the fracture. Therefore, they are easily fractured. Important is what should be done for investigation? Definitely only a chest x-ray is required, on which we can definitely see that the patient is having multiple rib fractures and the patient might have some respiratory difficulty. Otherwise, it will be absolutely normal. Only the problem that the patient will face due to this fracture is a lot of pain. And that is the reason in this condition, the treatment is only pain relief. That is nothing but analgesic should be given. It is nothing else but pain relief or analgesic should be given to the patient, painkillers. याद रखना, if they ask you during CPR, अगर CPR के दौरान कौन से ribs fracture होते हैं? During a CPR, because if you put a lot of pressure during the CPR, definitely which ribs get fractured? So it is the 3rd to the 5th ribs. ठीक है? So the most common ribs which are fractured definitely during a CPR is the 3rd to the 5th ribs. Due to trauma, it is usually the 4th to the 9th, but specifically during CPR, it is the 3rd to the 5th ribs usually. Okay, so that's the important thing. Now important is what is the most common cause of death in a case of thoracic trauma? Mortality is nothing but death. Mortality का मतलब ये होता है death. So most common cause of mortality or most common cause of death in a blunt thoracic trauma. Blunt thoracic trauma मतलब you fell from a bike, तो बाइक से नीचे गिर गए, okay, or definitely there was definitely a car which has actually hit you on the chest, definitely, okay, or there was a another vehicle which hit you on the chest, okay, so anything like that, or somebody has hit you with a bat, okay, किसी ने बैट से, लाठी से, हॉकी स्टिक से, कहीं से भी मारा, definitely on the chest. All of that is kind of a blunt trauma. So the blunt thoracic trauma to the chest, बच्चों, blunt thoracic trauma to the chest. What is the most common cause of mortality? You have to remember it is nothing else but tracheobronchial injury. If there is a blunt thoracic trauma, then the most common cause of death or the most common cause of mortality is nothing but the tracheobronchial injury or a tracheobronchial rupture. Trachea या bronchi फट जाता है तुम्हारा. Okay, there is a risk of injury to the trachea and bronchi which is going to cause death of the patient. I have told you na, tracheobronchial rupture or injury is the most common. It is one of the causes of death within 1 hour after trauma. ठीक है. Next important, penetrating trauma. Penetrating trauma to the thorax. For example, somebody actually stabs you with a knife or with a sword. Okay, किसी ने चाकू घुसा दिया या तलवार घुसा दी definitely chest में. Okay, that is what is a penetrating trauma. So most common cause of death or most common cause of mortality due to a penetrating thoracic trauma, बच्चे, it is going to be hemothorax. Now I have explained you what is a hemothorax. That too a massive hemothorax. ठीक, massive लिख रहे हैं ना. That is nothing but a massive hemothorax. Now hemo already I have told you what is hemo. Hemo means blood. Okay, and hemothorax means there is blood collection inside the pleural cavity. Okay, there's a lot of blood which collects inside the pleural cavity, and therefore this blood is going to compress the lung. As it is going to compress the lung is not able to expand, and as the lung is not able to expand, the patient has respiratory distress, due to which there is respiratory arrest and the patient dies. ठीक है. Penetrating thoracic trauma में the most common cause of death is usually massive hemothorax, and this massive hemothorax is secondary to, it is due to pulmonary contusions or pulmonary laceration. मतलब lung को injury हुई थी, there was actually injury to the lung and the lung started bleeding, and as there was a lot of bleeding from the lung, all that blood collected in the pleural cavity and it ultimately started compressing the lung itself. ठीक है, वो lung को ही compress करना शुरू कर देता है. Okay, so that is what is seen. This massive hemothorax is actually secondary or it is due to pulmonary lacerations or pulmonary injury, lung injuries. Okay. Now important is what is flail chest. This is a common question of your exam and a common thing also that you should all be aware of. What is a flail chest now? Shall I? So you have to remember flail chest ki definition says it is fracture of two consecutive ribs. It is a fracture of two or more consecutive ribs at two or more sites. What do I mean by this term? Let's understand this. So as I've told you, it is fracture of two or more consecutive ribs. Consecutive ribs मतलब एक के बाद एक. Okay. For example, first and second, second and third, third and fourth. These are called as the consecutive ribs. ठीक है. So fracture of two or more than that consecutive ribs at two or more than that places. Okay. Important is this is the definition which Bailey and Love. This is the definition which the ATLS protocol says. Bailey and Love gives another definition. It says fracture of more than equal to 3 ribs at more than equal to 3 sites. Okay, fracture of more than equal to 3 consecutive ribs at more than equal to 3 sites is what is called as a flail chest. So important is as we are following trauma, so we will follow the ATLS protocol more. But important is that definition is also right because it has been mentioned in the textbook. ठीक है, तो याद रख लो बात, दोनों भी definition correct हो सकती है. Please remember, don't just say कि नहीं नहीं यही एक correct है. Now what happens over here? See, क्या दिख रहा है यहाँ पे? Okay, can you just, I'll highlight it. Okay, so can you just see this rib is fractured over here and here, as well as it is fractured over here and here. This also, this ribs are fractured over here at this side particularly. Okay, and these ribs are also fractured over here. ठीक है, so can you see definitely यहाँ तो बहुत सारी है, but even if there are two ribs which are fractured, there are two ribs which are fractured which are consecutive, that means one after another. There are two consecutive ribs which are fractured at how many sides? At least 2 sides or more than that. This is what is called as a flail chest. ठीक है, अब क्या होगा इस वजह से बच्चे? So definitely 2 ribs are fractured, can you see? And they are one after another, that means both of them are consecutive ribs. And definitely they are fractured at how many sides? They are fractured at 1 and 2, 1 and 2. They are fractured at 2 sides. Now can you understand this part which is there? ये जो part है, this part of the ribs, it has got separated from the rest of the rib cage. बाकी rib cage से अलग हो गया ये part? Yes. This part is called as the flail segment. ये जो पार्ट होता है दैट इज कॉल्ड एज द फ्लायल सेगमेंट. एंड व्हाट इज इंपॉर्टेंट अबाउट दिस फ्लायल सेगमेंट, ये जो पार्ट है बच्चे, ये जो अलग हुआ पार्ट है फ्रॉम द रेस्ट ऑफ द रिब केज, दिस इज गोइंग टू मूव इन अपोजिट डायरेक्शन टू द चेस्ट. व्हाट डू आई मीन विद दिस? व्हेन द चेस्ट इज इंस्पायरिंग, this is going to go inside. Okay, when the chest is inspiring, this is going to expire, and when the chest is expiring, it is going to inspire. मतलब ये उल्टा चलेगा chest से. When the chest wall is going inside, it is going to come outside, and when the chest wall is coming outside, it is going to go inside. That means it will go into opposite direction of the chest wall. Rest of the chest wall will be moving in completely opposite direction of this flyer segment. ठीक है, तो याद रखना है. And this is what is called as opposite, is what is known as paradoxical. So therefore in this patient there will be a paradoxical chest wall movement, and this is very important keyword for your answer. जैसे ही वो क्वेश्चन में मेंशन करते हैं that the patient is actually having a paradoxical breathing or a paradoxical chest wall movement, please answer it as a case of flail chest. Okay, so please remember the flail chest is nothing but fracture of two ribs or more than that at more than equal to two sides. It is the patient will have a paradoxical chest wall movement, as I've told you. Apart from that, definitely the patient can have a lot of pain. There will be a lot of pain in the patient, and definitely the patient might have some respiratory distress. ज़्यादा नहीं होता. Some patients might have a severe respiratory distress. Otherwise, most of the patients will not have a severe respiratory distress. They will be walking patients. कोई दिक्कत नहीं आएगी. वो खुद चल के आएंगे हॉस्पिटल में. ठीक है? That is important. Now, what will be the management of this patient? So, if I talk about the management of this patient, you have to remember, बच्चे, here, as I've told you, the main complaint of the patient is not respiratory distress. The major complaint of the patient is actually a lot of pain. That is the reason why the first line management in a case of flail chest is nothing but painkillers, that is analgesics should be given. Adequate analgesia should be given. Okay, enough amount of painkillers should be given to the patient. If you give enough amount of painkillers to the patient, then definitely the patient's pain will be relieved, and then the patient will feel a lot of relief. कोई दिक्कत नहीं होती उसके बाद. But some patients will have some respiratory distress. So they, apart from analgesia, they might require a oxygen supplementation also. So some patients, apart from analgesia, they might require some oxygen supplementation. In that, you can just give a mask to this patient and you can start oxygen supplementation. Yes, a non-invasive ventilation can be started. You can just start oxygen supplementation in the patient with the help of a non-invasive mask. If that does not work, even if on oxygen supplementation the patient is having respiratory distress, then that definitely you have to go for a intubation. तुम्हें intubate करना पड़ेगा patient को, and you have to start the patient on IPPV. What is IPPV? I've already told you, intermittent positive pressure ventilation. When the machine is in control of his breathing, when the machine is giving positive pressure for his breathing, that is what is called as IPPV, intermittent positive pressure ventilation. If this also fails, all of this fails, then finally you might go for a surgical correction. But surgical correction is rarely required in a case of flail chest. Yes, flail chest में surgical correction is the last resort, and it is very rarely required. मैं इतनी बार बोल रहा हूँ, उससे ही समझ जाओ कितने patients में surgical correction लगता होगा. ठीक है? So that's the important funda. No issues with this anybody? That is important. This is the important management of flail chest. जैसे ही flail chest देखते हो तो immediately surgery and ये वो नहीं बोलना है. Okay, it is analgesia only. अगर patient is having respiratory distress, तो analgesia plus oxygen. If patient's condition is not only improving on oxygen, then IPPV. If IPPV is also failed, then we can go for surgical repair. ठीक है? Now if I talk about next one, that is your cardiac tamponade. Okay, in cases of cardiac tamponade, what is going to happen? Let's understand this first. Let's try to break it down. Okay, important is you will study similar kind of a situation, cardiac tamponade, in medicine. But over there, it is actually a complication of pericardial effusion. It is due to collection of fluid. I am talking about a cardiac tamponade again, but here it is due to collection of blood due to trauma. ठीक है? तो दोनों में similarities तो है, but definitely you have to remember both things are quite different. ठीक है? Important if I talk about a cardiac tamponade. What is tamponade? Tamponade is nothing but a pressure. And here on whom there is a pressure? Here there is actually a lot of pressure on the heart. Why? Because, for example, consider this as your outer covering of the heart. An outer covering of heart is known as pericardium. Then this is your heart. Okay, this is for example your heart. Now what has happened? There was a penetrating trauma to the chest. There was a penetrating trauma to the chest. सब किसी ने चाकू घुसा दिया यहाँ पे. And as there was a penetrating trauma to the chest, bache, definitely there was a lot of blood which collected inside the pericardium. There was a lot of blood which collected inside the pericardium. As there is so much of blood which collects inside the pericardium, it will start exerting a lot of pressure on the heart. It will start exerting a lot of pressure on the heart. As there is so much of blood collection in the pericardial cavity, it will start exerting a lot of pressure on the heart. As there is a lot of pressure on the heart, is the heart able to relax? No. As the heart is not able to relax, okay, as the heart is not able to open up, okay, so you have to remember, this is, for example, the heart, the four chambers. This is the superior vena cava, and we know that superior vena cava is connected to the internal jugular vein as well. Okay? So important is, as you can see, definitely the heart is not able to relax, and as the heart is not able to relax, definitely, please remember, will the blood be able to come inside the heart? No. As the heart is not able to relax, will the blood come inside the heart? No. Blood cannot come inside the heart because the heart is not able to relax. Therefore, the blood is not coming in the heart. That is, venous return is decreased. So if incoming blood is low, outgoing blood will also be low, and incoming blood is called as venous return. Outgoing blood is called as cardiac output. So definitely the patient's cardiac output is going to be low. And I've told you, cardiac output decides the blood pressure of the patient. So if cardiac output of the patient is low, blood pressure of the patient is going to be low as well, right? Therefore, the patient has the first feature known as hypotension. Patient will have hypotension. Second important is, as you can see, the heart is not the blood is not able to come inside the heart because the heart is not relaxing. Therefore, all that blood keeps on collecting over here. All that blood keeps on collecting over here. Therefore, what will happen to the pressure inside the internal jugular vein? As there is a lot of blood which is collected inside the internal jugular vein, your internal jugular vein will be full. पूरी full जाएगी तुम्हारी internal jugular vein, and the pressure inside the internal jugular vein is going to rise. And we know what is the internal jugular vein pressure called as? It is known as JVP. So it is the jugular venous pressure. So definitely the patient's jugular venous pressure is going to rise. Normally जब भी jugular venous pressure increase होता है बच्चे, it is pulsatile. But in a case of cardiac tamponade, there is a non-pulsatile JVP. Yeah, there is a non-pulsatile raised JVP. In all other conditions, there is a pulsatile raised JVP, but in this condition, there is a non-pulsatile raised JVP that you have to remember. And third important, if you want to auscultate the heart of the patient, if you want to hear the heart sounds S1 and S2, there is a lot of blood now. Will you be able to hear the sounds clearly? No, you are not able to hear the sounds clearly. And that is the reason why you will be able to hear the sounds, but they are not clear, as I've told you. They are muffled. ठीक है, धीमी धीमी आवाज आएगी तुम्हें. They will be muffled, and these are called as a muffled heart sounds S1 and S2. And this is the classical triad known as the. Okay, so please remember, टूटे हुए रिब्स अपने आप जुड़ जाते हैं. Please remember that. So this is important, as the blood is not able to come inside the heart. Therefore, all that blood keeps on collecting inside the superior vena cava, and all that blood keeps on collecting inside the internal jugular vein. Okay. Important is, as the pressure inside the internal jugular vein keeps on increasing, therefore we can say the JVP of the patient is constantly rising. The patient is going to have a raised jugular venous pressure. This jugular venous pressure, whenever it raises, now whenever it increases, it is usually pulsatile. Okay, but in a case of cardiac tamponade, there is a non-pulsatile raised JVP in the patient. Okay, so that is the feature, and this is the classical Beck's triad of cardiac tamponade. So let's write down it. Okay, let's write it down. Important is first, bacho, definitely you have to remember cardiac tamponade. Okay, that is nothing but pressure on the heart. Tamponade is pressure, cardiac means heart. So there is excessive pressure on the heart. Why? Because there is rapid collection of blood in the pericardiac space. There is rapid collection of blood in which space? In the pericardiac space. What is the most common cause responsible for it? The most common cause responsible for it is actually penetrating trauma to the chest, right? The most common cause responsible for it is actually a penetrating trauma to the chest. Now, due to that penetrating trauma, there is a lot of blood collected in the pericardial cavity, and therefore it is exerting a lot of pressure on the heart. That is the reason why heart is not able to relax. Therefore, the blood is not able to come inside heart. Therefore, incoming blood is low, outgoing blood is low. That is the reason the patient is having hypotension. So there is decreased venous return, there is decreased cardiac output, and that is going to cause hypotension or decreased BP in the patient. That is going to cause hypotension or decreased BP in the patient. First feature. Second feature, as I've told you, definitely all this blood keeps on collecting inside the superior vena cava and thereby in the internal jugular vein. So therefore, the patient is going to have raised JVP, but there will be a non-pulsatile raised JVP. There will be a non-pulsatile raised JVP. Okay, and third feature that you have to remember, the patient is going to have, on auscultation, the patient is going to have muffled heart sounds. There will be muffled S1 and S2 heard on auscultation. Muffled heart sounds will be heard. Okay, so that is important. These three features together, hypotension, raised JVP and muffled S1 and S2, muffled heart sounds. These three features together are classically known as the Beck's triad of cardiac tamponade. They are classically called as the Beck's triad. They are classically called as the Beck's triad of cardiac tamponade. No issues with this. They are known as the Beck's triad of cardiac tamponade. Got it? So that is important to be remembered, bacho. Okay. Now important is you have to remember this key. As you can see over here, around the heart there is a lot of blood. Ye previous year image based question hai tumhara. This was the image based question of December 2021. Can you see here there is a heart which is having a lot of blood collected outside. Okay, and therefore it appears black completely. And this is what is the case of cardiac tamponade. Yes. The other option which was there, which was given in the question was necrosis, fat necrosis. But it is not a case of fat necrosis. This is an autopsy picture on which it is showing you the cardiac tamponade usually. ठीक है, तो याद रखना ये picture important है, या आ चुकी है exam में. Important is what is done for the investigation. So you have to remember, बच्चों, the first line investigation which is there, the first line investigation which is used for diagnosis is definitely a FAST. What is a FAST now? As I've told you, FAST is nothing but a rapid ultrasound which is done in a case of emergency. FAST is focused assessment by sonography in trauma. Focused assessment. That means we are going to examine only certain parts. Okay. Sonography is nothing but ultrasound in a patient of trauma. That is what is a FAST. So FAST में the सबसे पहला जो pass होता है, we are going to keep the ultrasound probe in various sites of the abdomen. We are going to keep this ultrasound probe at various sites on the abdomen. But the first site where we keep this ultrasound probe is actually the subxiphoid space. Xiphoid, xiphy sternum ke just niche. We are going to keep the ultrasound probe in the subxiphoid space. Okay, and then we are trying to rule out any pericardiac blood collection. That means we are trying to rule out any cardiac tamponade. जो सबसे पहले चीज करते हैं हम फास्ट पे बच्चे, we are going to try to rule out the cardiac tamponade itself. Yes, fast it is done for abdomen, but the most important thing is it is not only done for abdomen. You have to remember the first thing that we actually try to rule out is the cardiac tamponade. Okay? Because it is going to cause immediate death in the patients within 1 hour itself. Next important, you have to remember what is the investigation of choice. The investigation of choice for a patient of cardiac tamponade is going to be an echocardiography. The investigation of choice for a patient of cardiac tamponade is going to be an echocardiography. Please remember that. Okay? Now what should be the management in this patient? So you have to remember the management in emergency and the definitive management is going to differ. What is done from emergency management of this patient? So emergency mein we are going to take a needle, okay, which is attached to a syringe, and we are going to perform echocardiography of this patient. Under that echocardiographic guidance, okay, what we are going to do, we are going to insert this needle from the subxiphoid space. We are going to insert this needle from the subxiphoid space at a 45-degree angle. Okay, and it is going to face towards the left shoulder tip. This needle is going to face towards the left shoulder tip. We are going to insert it from the subxiphoid space at 45-degree angle. Okay, under ultrasound or under a echocardiographic guidance only. Okay, and then we are going to take this needle till the pericardiac cavity, and then once the needle is inside the pericardiac cavity, definitely we are going to aspirate the blood. We are going to remove the blood. At least even if we remove 10 cc of blood, हम अगर 10 cc का भी blood निकाल देंगे, then also there will be drastic improvement in the patient's condition. Yes, there will be drastic improvement in the patient's condition that you have to be aware of. Okay? And this condition where we are actually inserting a needle in the pericardiac space of the patient is known as needle pericardiocentesis. Okay? So emergency management in a case of cardiac tamponade, you have to remember it is known as needle pericardiocentesis. Okay, it is known as needle pericardiocentesis. This has been a previous year question. Please be aware of this. What is done for emergency management in a case of cardiac tamponade? It is needle pericardiocentesis. Important is in a patient of cardiac tamponade, we are going to insert this needle, okay, in the subxiphoid space. In the subxiphoid space. At what angle? At 45-degree angle. Okay. towards the left shoulder, facing towards the left shoulder. Okay, that is how you are going to insert that needle. And this pericardiocentesis which is there, it should always be done under echocardiographic guidance by. Okay, it is always done under echocardiographic guidance. Otherwise, you are going to injure the heart. वो कांड नहीं करना है. Don't go for a blind pericardiocentesis ever. Okay, otherwise there will be injury to the heart. Okay, जो patient 1 घंटे बाद मरने वाला था, पता चले वो 5 मिनट में गया. ठीक है, so that should not happen. Next important is definitely we are going to talk about the definitive management for cardiac tamponade. If I talk about the definitive management of a cardiac tamponade patient, you have to remember, okay, you have to remember in definitive management, we have to open up the thorax of the patient and we have to operate the patient in the OT. For definitive management, we have to do an emergency thoracotomy. What is opening the thorax called as thoracotomy? So here we have to open up the thorax of the patient and we have to operate. That is emergency thoracotomy should be done in a patient of cardiac tamponade. Okay, emergency thoracotomy should be done in a patient of cardiac tamponade. कोई इसमें that is the important thing that you have to be aware of. ठीक है, तो cardiac tamponade में याद रखना है कि penetrating trauma is an important cause. Okay, Beck's triad is classically seen. 3 features are hypotension, raised JVP, muffled heart sounds. First line is fast. So investigation of choice is the echocardiographic guidance. Emergency management is nothing but needle pericardiocentesis. Okay, whereas definitely definitive management of the patient is going to be a immediate or an emergency thoracotomy. Okay, immediate or an emergency thoracotomy. No issues with this, anybody? That's important. Now let's talk about the next question, which states, the next question states, a person met with a road traffic accident and he has been brought to the emergency room with severe breathlessness. On examination, congested neck veins are seen and there is absent air entry and breath sounds. This is a classical case of tension pneumothorax. Okay, and what will be the management of this patient? So let's talk about that. So now let's talk about a case of tension pneumothorax. First of all, why it is called as pneumothorax? Understand. So as I've told you, this is the lung. The covering of the lung is known as the pleural cavity. The covering of the lung is known as the pleura. And this which is there is known as the pleural cavity. Got it? Important is what happens. Normally, yaad rakhna, if there is any injury to the pleura, as there is negative pressure, as there is a negative pressure inside the pleural cavity, okay, injury to the pleura will actually suck in a lot of air. उसमें बहुत ज़्यादा air खींच लेगा, and therefore there's a lot of air which gets rapidly collected. There's a rapid collection of air inside the pleural cavity. As there is a lot of air which collects inside the pleural cavity, this air is going to cause pressure. This air is actually going to exert a lot of pressure on the lungs. So will your lung be able to expand? No, your lung is not able to expand. And as the lung is not able to expand, that is the reason the patient is going to experience breathlessness or respiratory distress. Got it? This is a case of pneumothorax. Why? Because there is collection of air inside the pleural cavity. That is your thorax. So therefore air is known as pneumo and pleural cavity is present in the thorax. Therefore it is pneumothorax. Got it? Important. One reason I've told you that it can be due to injury to the pleura. But another reason, as I've told you, it can be due to injury to the lung also. If there is injury to the lung, then also the patient can develop pneumothorax. How? Because definitely what is present inside the lung? Air. So definitely all that air is going to come outside. All that air will come outside in the pleural cavity and it is going to, all that air which is there, it is going to come inside the pleural cavity and all that air will be collected inside the pleural cavity. And now this excess of air which has come from the lung, it is going to try to compress the lung itself and this will cause pneumothorax in the patient. Important is the first condition that I described, when there was an injury to the pleura, that was actually called as an open pneumothorax. Reason is because over there definitely the air was coming from outside, from the environment, because there was injury to the pleura. But here the actually air is coming from the lungs itself. This is called as a closed pneumothorax. Both of them can lead to a tension pneumothorax. Now what is a tension pneumothorax? You have to remember that tension pneumothorax, why it is called as tension, sabse pehle to understand. Tension pneumothorax, because in this patient of pneumothorax, the patient will not only have respiratory distress, but the patient's blood pressure is going to fall. Yes, the patient's BP is going to fall. He is going to suffer from hypotension and the patient will be hemodynamically unstable. तुम बोलोगे ये pneumothorax का patient अचानक से hemodynamically unstable क्यों हो गया? Just understand it. How? Because this patient who is having a lot of pneumothorax, okay, lot of pneumothorax is there. Okay, this is another lung over here, for example. What is this? Definitely ये छोटू सा क्या है तुम्हारा? This छोटू is nothing but your heart. ठीक है. Now all of this air which has been collected in the lung and in the pleural cavity, this is actually swelling up and therefore it is compressing your heart. Okay, the affected side which is there bachcho, wherever there is collection of air in the pleural cavity, that side will be compressing your heart. As it is compressing your heart, is your heart able to expand? No. As there is a lot of compression from the lung, the heart is not able to expand. And as the heart is not able to expand, will there be blood coming inside the heart? No. We know whenever the heart does not relax, the blood is not able to enter inside the heart. Therefore, the incoming blood is low, outgoing blood is low. Incoming blood is known as venous return, outgoing blood is known as cardiac output. And if cardiac output of a patient is low, the blood pressure of the patient is going to fall. That is the reason why the patient will be having low BP or hypotension, due to which we will say that a patient of pneumothorax can land up into hemodynamic instability, and that type of pneumothorax which causes hypotension is known as tension pneumothorax. Okay, that is what is known as a tension pneumothorax. कोई दिक्कत नहीं है इसमें. Let's write down now. So tension pneumothorax, you have to be aware of this key. It is due to rapid collection of air. It is due to rapid collection of air in the pleural cavity. It is due to rapid collection of air in the pleural cavity. Okay, which causes collapse of lung. And as the lung is collapsed, definitely it is not able to expand. Okay, and therefore patient has respiratory distress. So rapid collection of air in the pleural cavity which causes collapse of lung and hemodynamic compromise. क्योंकि अगर hemodynamic compromise नहीं होगा, it will be a simple pneumothorax. It cannot be a tension one. Tension one है, so definitely it is due to the low BP in the patient. That means definitely the patient's BP is low. Okay. Important is you have to remember how to identify a case of tension pneumothorax clinically, even in a question. Reason is why. हमें क्यों chest X-ray की जरूरत नहीं है? बच्चे, important is in a patient of tension pneumothorax, the patient is having severe respiratory distress. Even sometimes you do not have time for chest X-ray. So in that condition, you have to just clinically suspect that this patient might be having a tension pneumothorax, and depending on your clinical decision, you have to go for the emergency management, which is nothing but take a wide bore needle, badi si ek needle lo, take a wide bore needle and insert in the intercostal space of the patient. As you insert this wide bore needle in the intercostal space of the patient, all that air which was collected inside his pleural cavity, via this needle, through this needle, all that air is going to escape out. And as the air starts escaping out from the pleural cavity, definitely the lung starts to expand. And as the lung starts to expand, the patient respiratory distress is going to decrease. Okay, that is the important thing. That management is known as needle thoracocentesis. Wahan pe it was needle pericardiocentesis, but here we are actually inserting the needle inside the thorax. Therefore, it is known as needle thoracocentesis. For this, chest X-ray is not required. For this, your clinical decision is required. That is the reason why you have to remember what are the classical clinical findings in a patient of tension pneumothorax. I always say I always combine it in a form of ABC. तो ये ABC तुम्हें भी याद रखना है. ABC of tension pneumothorax. What are those? If those are present in the question, that is a classical diagnosis of tension pneumothorax. ठीक है? Just look at those ABC. So clinically, if I talk about बच्चे, the patient is going to have A, B, C, and these ABC of tension pneumothorax. First of all, A, that means on auscultation, what we are going to find actually on auscultation of this patient, on auscultation of the chest of this patient. Clinical is auscultation, okay? So auscultation of the chest of this patient, the patient is going to have जिस side पे अगर lung collapsed है, will there be air entry on that particular side? No. So the air entry is going to be absent. And will there be breath sounds in that particular side? No, again, there will be absent breath sounds. So you have to remember on the affected side, okay, on the affected side, the patient is going to have absent air entry. The patient is going to have absent air entry and breath sounds. So either they can mention absent air entry or they can mention absent breath sounds. That's fine. Okay. So absent air entry or absent breath sounds on the affected side is the first A that you have to remember. Okay. In a case of tension pneumothorax. Second, B stands for what? What is the major complaint of the patient? B stands for breathlessness. Yes. So you have to remember B does not stand for anything else. B is just the breathlessness. Okay, just a minute. B is nothing but the breathlessness of the patient. So the patient is going to be very, very breathless in this condition. B stands for breathlessness, but they can mention this breathlessness as shortness of breath, respiratory distress, falling SpO2, कुछ भी बोल सकते हैं. That is what is breathlessness itself. That is what is breathlessness itself. ठीक है. Next important you have to remember C. Now definitely what did I tell you बच्चों? That the blood is not able to come inside the heart. If the blood is not able to enter in the heart, it will keep on collecting in the superior vena cava, and from the superior vena cava it will keep on collecting inside the internal jugular vein. Therefore the internal jugular vein or all your neck veins will have a lot of blood inside them, and therefore that neck veins will become full or congested neck veins they will write. Okay, so C stands for the congested neck veins. Okay, so C actually stands for the congested neck veins, because the patient has all the blood which is collected inside the neck veins itself. There will be congested neck veins. They can also describe it as raised JVP, because if there is so much of blood inside the neck veins, the patient is also going to have increased jugular venous pressure. The patient can also have raised JVP. कोई दिक्कत नहीं है इसमें. That has to be remembered. Important is बच्चों, apart from this what will be seen? This is the clinical finding. This is what is the clinical finding. This ABC can make your diagnosis very clear. Okay. Now apart from this, as I've told you, definitely the patient's heart is getting compressed. Therefore there is decreased venous return, and due to decreased venous return there is decreased cardiac output, and that is causing decreased blood pressure, that is hypotension in the patient. So the patient is going to have hypotension. Therefore we are actually calling it tension pneumothorax, right? That is the reason why we are calling it tension pneumothorax. Apart from that, when I'm going to percuss the patient, I hope all of you know percussion, when we actually percuss the chest. Okay, middle finger over the middle finger, definitely. Okay, and when you percuss the chest, definitely, normally due to the presence of air, we are going to get resonance. But as there is so much of air now, there is so much of air over here, therefore we will get a hyper resonant note. Okay, we are going to get a hyper resonant note. Okay, so that is important. On percussion, definitely percussion pe there will be a hyper resonance which is noted. There is hyper resonance on percussion, that has to be remembered. कोई दिक्कत नहीं है इसमें. Auscultation पे तो I have told you, on the affected side there will be absent air entry and there will be absent breath sounds as well. Okay, so these are the classical signs. And now definitely if I talk about the chest x-ray of the patient, what will be seen on the chest x-ray of the patient? CC is nothing but chief complaint, okay, or clinical complaints, whatever you write. Okay, so important is definitely, if I talk about the chest x-ray of the patient, we know that the first line investigation in a patient, of pneumothorax is going to be at the chest x-ray. And if I go for a chest x-ray, as I've told you, chest x-ray for all other conditions is taken in expiratory view. Chest x-ray for all other conditions is taken in inspiratory view except for pneumothorax, where it is taken in the expiratory view. Okay? Important is क्या दिखेगा? Can you see on the right side of this patient? Okay, there is more blackening. Normally the lung does not appear so much black. It is more black over here. This is called as increased blackening, or we can call it black is lucent. Therefore we can even call it as hyperlucency. That is the first feature. Second, can you see the shadow over here? This shadow is nothing but your collapsed lung itself. ये जो shadow दिख रही है ना, this is nothing but your collapsed lung. So on the affected side, definitely you are able to see there is a collapsed lung, and there is hyperlucency. Hyperlucency I have already told you, it is nothing but increased blackening. So whatever they can write. Okay. Apart from that, now there is so much of air on the affected side that your diaphragm is also pushed downwards. There is so much of air on the affected side. Normally there is a dome of diaphragm, but there is so much of pressure from above that your diaphragm is also flat now, right? So there is flattening of diaphragm which is seen. There is flattening of the diaphragm which is seen, that you have to remember. There is flattening of diaphragm which is seen. Okay, that is the next feature on the chest x-ray, flattening of diaphragm. Next important feature that you can see, this is a very classical feature, and that is what is called as the deep costophrenic angle, which is known as a deep sulcus sign. ठीक है, deep sulcus बोलो या sulcus बोलो. Normally जो costophrenic angle होता है, okay, it is blunted in pleural effusion and deep in cases of pneumothorax. So you have to remember that this is what is called as the deep sulcus sign, which is a very characteristic feature. I am saying characteristic, मतलब not present in other conditions. ठीक है, so this is called as the deep sulcus sign. So this deep sulcus, your deep sulcus sign which is there, it is a characteristic feature of pneumothorax on the chest x-ray. Okay, so the deep sulcus sign will be seen in the patient, deep sulcus sign. And last important feature that you can see over here, can you see that the trachea is shifted to the opposite side? Yeah, there is so much of pressure that the trachea is kicked, or the trachea is shifted to the opposite side. Due to the pressure, the trachea is also shifted to the opposite side. Opposite is what is called as contralateral. So therefore we can see a contralateral tracheal shift. We are able to see a contralateral tracheal shift on the chest x-ray. These are the features. Along with that, there is one more feature. I'm just telling it to you. At least these are important. These should be remembered. Next, can you see any markings over here? No. Normally जो chest x-ray होता है बच्चों, उसपे थोड़ी बहुत तो white markings दिखती है ना. Normal chest x-ray पे there will be some kind of white markings. Those white markings are nothing but the bronchus and the vessels. But here you are not able to see any bronchovascular markings because there's a lot of air around the lungs. Okay, the lungs are collapsed. That is the reason why bronchovascular markings are absent. Okay, this will help you differentiate this x-ray from an x-ray of emphysema, where bronchovascular markings are present along with hyperlucency. Okay, so that is the important feature, bache. No issues with this, anybody? Can we also say infarct? Infarct क्यों होगा? Why there will be infarct? The first line is definitely chest x-ray, okay, on which there will be a collapsed lung along with hyperlucency, flattening of diaphragm, contralateral tracheal shift, deep costophrenic angle known as the deep sulcus sign. Okay, so these are the important features on a chest x-ray of pneumothorax. Now, if we want, we can even go for another investigation. And what is that another investigation? We can go for an ultrasound, and that ultrasound which is done in a case of emergency is what is called as a FAST. Okay, and on that FAST, bacho, what will be seen? Let's see this. Now, in a normal lung, what is seen on a ultrasound? Definitely you can see that the chest wall normally does not move, but the lung has a motion. The lung is usually in motion. As the lung moves, it appears like a beach. Okay, as the lung moves and the chest wall is stable, definitely it appears like a beach. Therefore, it is called as a beach sign or the seashore sign. Normally, lung on a ultrasound or on a FAST is called as the seashore sign. But in a case of pneumothorax, now we know that the lung is completely collapsed. Is there any movement in the lung? No, there is no motion inside the lung, and the chest wall is always stable. Na? Chest wall to kabhi move nahi karti. So definitely the chest wall is also stable and the lung is also stable now. Therefore, this is what is called as the barcode or the stratosphere sign. So you just have to remember the name, bache. So please remember, in a patient of pneumothorax, which sign is seen on an ultrasound or a FAST? The sign which is seen in a patient of pneumothorax on an ultrasound or a FAST is actually the barcode or the stratosphere sign. Seashore sign is seen in normal lung. याद रखना ये बात. Don't confuse it with this. कि normal lung में there is a seashore sign, but in a patient of pneumothorax there is actually a barcode or a stratosphere sign. कोई दिक्कत नहीं है. That is important. Now, what is the treatment of this patient? Once we have diagnosed this case, what is the treatment of this patient? Let's talk about that. In emergency, as I've told you, we don't even need a chest x-ray. Forget about the FAST. We don't even need a chest x-ray to make a diagnosis of tension pneumothorax. Okay, in this definitely we can directly take a wide bore needle, 14-16 gauge needle can be taken. Okay, and we are going to insert it in the intercostal space. What is the intercostal space? The space between the two ribs. We are going to insert it in the intercostal space of the ribs, and as we insert this in the ribs, definitely all the air which has been collected in the pleural cavity, jitni bhi air hawa bhari padi hai, all that air is going to escape via this needle, right? That procedure is known as needle thoracocentesis. So emergency management is known as needle thoracocentesis. The emergency management is known as needle thoracocentesis. And you have to remember the needle thoracocentesis which is done, okay, the site for inserting this needle is changed according to the ATLS protocol. Harrison's have not changed it yet. Therefore, medicine maybe people might be telling you the same thing, but definitely ATLS has changed the guidelines, and this tension pneumothorax wala patient comes to mainly the surgery emergency, and as it is a case of trauma, therefore we are going to follow the ATLS guidelines. Okay? If I talk about the ATLS guidelines, it says definitely in an adult, you have to insert this needle pericardios, you have to do this needle thoracocentesis, or you have to insert this wide bore needle in the fifth intercostal space, just anterior to the mid axillary line, just anterior to MAL. MAL is nothing but mid axillary line, or we can say on the mid axillary line also, that's fine. Kaha hoti hai mid axillary line? This is what is your mid axillary line. So over here in the fifth intercostal space, you are going to take a needle and you are going to insert it in the intercostal space, the fifth one. Okay? But in a child it is the same. Child mein neither the ATLS protocol nor the Harrison is differently. Both of them agree that in a child definitely you have to insert it in the second intercostal space on the mid clavicular line. This is your mid clavicular line. On the second intercostal space over here, you are going to insert the needle for needle thoracocentesis. So here it is the second intercostal space on the MCL. MCL is nothing but the mid clavicular line. Okay, so second intercostal space on the mid clavicular line. This is very very important बच्चे. This is very very important. Now ये सबको आता था. Okay, why I'm going to teach you, why I'm teaching you this trauma in so much of depth. ये सबको पता था ना. 30th July examination, definitely there was a question that you insert this needle in a case of needle thoracocentesis. Where exactly? Upper border of lower lip, lower border of upper lip. Okay, so upper border of lower lip, lower border of lower lip, upper border of upper lip, lower border of lower upper lip. तो ऐसे combinations आए थे. Okay, so that is actually confusing at times. So it's easy, don't worry about that. See, क्यों होता है मैं बता रहा हूँ. Important is, this is first rib, this is the second rib, this is your upper rib, this is your lower rib. Now important is, this is what is your intercostal space. Now in the intercostal space you have to remember the vessels which are there, bachcho. The vessels which are there, definitely these vessels just pass at the lower border of the upper rib. These vessels which are there, they just pass at the lower border of the upper rib. That is the reason why these intercostal space, these intercostal vessels which are there, they are at the they are at the lower border of the upper rib. Therefore, you have to insert the needle where exactly? You have to insert the needle over here. That means at the upper border of the lower rib. क्योंकि यहाँ भी vessels होंगे. Okay, there will be vessels over here as well. Okay, so therefore, the site of needle insertion should be at the upper border of the lower rib. Okay, the site of insertion should be exactly at the upper border of the lower rib. No issues with this, anybody? So exactly you have to remember the needle insertion which is done. I'll write over here needle insertion. The needle insertion which is done, it is done at upper border of lower rib. It is done at upper border of lower rib. No issues with this, anybody, bachcho? Due to the risk, to avoid any injury to the intercostal vessel, that is the logic behind it. Okay, no issues with it. That's the important thing. Now what about the definitive management? Because this was just the emergency management. If I talk about definitive management in the patient, you have to remember definitely definitive management mein we have to take up the patient for a ICT insertion. What is ICT now? See, ICT is nothing but, for example, this is your pneumothorax wala patient. Okay, here we are actually going to insert a tube. And that tube which is there, it will be connected to a bag, and this bag which is there, it will be having fluid inside it. This bag which is there now, it will be having fluid inside it. It will have fluid. Till this level you have to fill up the fluid. Reason is, हमें fluid क्यों fill करना है अभी? So please remember, if you do not fill up the fluid, what is going to happen? The air is going to come out via this. The air is going to definitely come out via this tube. But the problem is, air is coming out and again the air can go in, because it will be both way na entry. That is the reason. So you have to always insert the ICT. This is the ICT, intercostal drainage tube. This is the ICT, intercostal drainage tube. You can even call it ICD. That's the one and the same thing. Yeah, like now from this ICT now, the air is going to come outside. Okay, from this ICT, the air is going to come outside. It is going to come inside this fluid and it is going to bubble out. अब वापस fluid जाएगा क्या? नहीं जाता. ठीक है? So that is the reason definitely you always have to insert ICT with the underwater seal. हमेशा एक underwater seal की जरूरत होती है. You never insert ICT without underwater seal. If you want to empty the bag, you have to clamp the ICT. पहले ICT को बंद करो, then पानी खाली करो उस bag में से, and then again fill up new water, and then again open the ICT. If you don't do this, patient's pneumothorax is going to increase. Okay, तो ये नहीं करना है हमें. Definitive management, बच्चे, you have to remember the definitive management of the patient is going to be what? It is going to be ICT insertion with underwater seal. So ICT insertion. Okay, ICT is nothing but, as I will write down, ICT insertion with the underwater seal. As I've told you, ICT is nothing but an intercostal drainage tube. ICT is nothing but an intercostal drainage tube. No issues with this, anybody? That has to be remembered. Important is now, what is the site of insertion of the ICT? कहाँ से डालते हो usually this ICT? You have to insert it in the fifth intercostal space. Exactly where? In the triangle of safety. अब ये triangle of safety क्या बला है? It is actually fifth intercostal space, mid-axillary line only. But the better term that they use in ATLS protocol is the triangle of safety. So better we call it triangle of safety only. ठीक है? तो कहाँ पे डालना है this ICT? We have to insert this ICT बच्चों in the fifth intercostal space in triangle of safety. In the fifth intercostal space in the triangle of safety. What are the borders of this triangle of safety? I'll talk about this now. Just a minute. Okay, fifth intercostal space, triangle of safety में डालना है. What are the borders of this triangle of safety now? The border of this triangle of safety are. Okay, the borders of this triangle of safety are. Shall I? See, the anterior boundary or the anterior border which is there. The anterior border is formed by this muscle. What is this muscle? Pectoralis major muscle. So the anterior border of the triangle of safety is formed by the pectoralis major muscle. The posterior boundary is formed by this muscle, latissimus dorsi. Posterior boundary is formed by the latissimus dorsi muscle. The apex is formed by the base of axilla. The apex of this triangle of safety is formed by the base of axilla. Okay, and the lower border is formed by the fifth intercostal space itself. Lower border is formed by the fifth intercostal space itself. No issues with this, anybody? That's the important thing. So triangle of safety जो है, it is actually between the anterior boundary is nothing but the pectoralis major muscle. Okay, it is nothing but the pectoralis major muscle. The posterior boundary, as I've told you, it is the latissimus dorsi muscle. The posterior boundary which is there, it is nothing but the latissimus dorsi muscle. Okay, at least remember these two. The apex which is there, it is formed by the base of axilla. The apex which is there, it is formed by the base of axilla. Okay, and the inferior boundary which is there, the inferior boundary, it is actually formed by the fifth intercostal space. The inferior boundary is formed by the fifth intercostal space. These are the borders or these are the boundaries of your triangle of safety. Okay? Important is now what should be done that even after inserting the ICT, the patient's condition is not improving. In that condition, you have to open up the thorax of the patient, that is thoracotomy. What are the indications of thoracotomy? Let's see that. Okay, what are the conditions in which we have to open up the thorax of the patient? So if I talk about indications of thoracotomy, you have to be aware. Indications of thoracotomy, what are these? Question आया हुआ है इस पे. So definitely indications of thoracotomy will be as soon as you have inserted the ICT. जैसे ही तुमने ICT डाली, there is more than 1.5 liters of blood which has come inside the ICD bag. Inside the ICD bag, there is more than 1.5 liters of blood which has collected. So it is a case of hemothorax, and that too not a mild or moderate hemothorax. That is the case of massive hemothorax. Because more than 1.5 liters of blood has come over here. Okay? So if there is more than 1.5 liters of blood output at the time of ICD insertion itself, dalte there is more than 1.5 liters of blood. Definitely that is an indication to open up the thorax. Second, if there is more than 200 cc per hour of output for 3 consecutive hours. After inserting the ICD for the first 3 hours, continuous 3 hours, there was more than 200 ml or 200 cc of output every hour. Every hour there was more than 200 ml of output. हर घंटे 200 ml से ज्यादा का आउटपुट आ रहा था इन द आईसीडी बैग फॉर द फर्स्ट 3 आवर्स, पहले 3 घंटे तक लगातार. ठीक है, सो मोर देन 200 cc ऑफ आउटपुट फॉर द कॉन्सेक्यूटिव 3 आवर्स. इट इज आल्सो एन इंडिकेशन ऑफ thoracotomy. We have discussed already about cardiac tamponade. We know that cardiac tamponade is always an indication of thoracotomy. I'm not writing over here. The other indication of thoracotomy will be tracheobronchial injury. If there is a tracheobronchial injury, as we know, the patient can land up into death. That is the reason tracheobronchial injury is an example of, is an indication of thoracotomy. And last is esophageal rupture. Okay, esophageal rupture, we will talk about that in Boerhaave syndrome. So esophageal rupture is also an example of, also an indication of thoracotomy. Okay, so the conditions where thoracotomy is done, you have to remember 5 conditions. More than 1.5 liters of blood coming out immediately at the time of ICT insertion. More than 200 ml per hour of output in the first 3 consecutive hours. Tracheobronchial injury, esophageal rupture and cardiac tamponade. Okay, chalo. Done with this, bache? That was all about your thoracic trauma now. Now last one that we are going to talk about in trauma, and that is what is your abdominal trauma. Okay, that is what is your abdominal trauma. No issues with this, anybody? Do you want a small break before abdominal trauma? 10 minutes, then we can continue further. If you want a small break, let me know. Then definitely we can continue further. So abdominal trauma will be in one go itself. मुझे वापस उसके बीच में ब्रेक नहीं देना फिर बीच बीच में. That's the reason. Okay. Okay. Chalo, let's take a small break, 10 minutes max. Okay. So then we can start with abdominal trauma, because abdominal trauma is important. So you'll be able to get abdominal trauma easily. ज़्यादा नहीं abdominal trauma में, don't worry about that. So once we're done with abdominal trauma, we'll do bunks थोड़ा सा, and then maybe we'll wind up the session for today. ठीक है? चलो. Is it fine now? Is it fine now? Okay, chalo. Hopefully it's audible. Now let's talk about, very good, chalo. Let's talk about abdominal trauma, bache. It is important to understand abdominal trauma. If I talk about abdominal trauma, this question first of all, it says a 17-year-old girl presents to the emergency department with a stab wound. Okay, stab wound, that means it is kind of a penetrating injury or a penetrating trauma. Stab मतलब किसी ने चाकू घोप दिया या छुरा घोप दिया. Okay, there is a stab wound to the abdomen of this patient in the anterior axillary line at the right costal margin. The blood pressure of this patient is 80 by 50 millimeters of mercury. That means we know that the blood pressure of this patient is falling and the pulse rate is 120 beats per minute. As the pulse rate is more than 100 beats per minute, we know it is a case of tachycardia as well. The respiratory rate of the patient is 28 breaths per minute. Normally we know that the respiratory rate is usually between 12 to 20 breaths per minute. Here it is high. Two large bore IV lines have been inserted. A nasogastric tube, that is your Rice tube, and a Foley's catheter are also inserted. Blood pressure of the patient rises to 90 by 60 millimeters of mercury after 2 liters of Ringal lactate. Appropriate management is. So you have to answer this question, but once we discuss the abdominal trauma, right? Now, important is, if I talk about abdominal trauma, these are the important one-liners which have been asked from the topic. Important is, in a case of blunt abdominal trauma, bache, which is the most common abdominal organ injured? In a case of blunt abdominal trauma, the most common abdominal organ injured is the spleen, followed by the liver. Okay? The most common abdominal organ injured in a case of blunt abdominal trauma is the spleen, followed by liver. Whereas if I talk about a penetrating trauma to the abdomen, penetrating trauma means, for example, somebody has stabbed with a knife or a sword. For example, a penetrating abdominal trauma, definitely the most common organ injured in that condition is the liver. The most common organ injured in penetrating abdominal trauma is the liver, followed by the stomach, followed by the small intestine. Okay, followed by the stomach, followed by the small intestine. No issues with this, anybody? So penetrating abdominal trauma mein, it is the liver, followed by the stomach, followed by the small intestine. कोई दिक्कत नहीं है इसमें, that has to be remembered. Next important is, if I talk about the seat belt trauma. This is a previous year question again. If I talk about the seat belt trauma, you have to remember, for example, you are driving a car and there is a seat belt that you have applied. Due to some accident or as you suddenly applied a brake, definitely there was a hyperflexion. And as you go into sudden hyperflexion, definitely what is going to happen? You have applied a seat belt. So दिक्कत कोई नहीं आती. But the problem is, definitely there is a lot of strain, there is a lot of pressure on your abdominal organ. And definitely all your abdominal organs which are there, or your intestine which are there, na, they will be pulled ahead. Okay, important is, these abdominal organs which are there, they are connected with the help of a fatty tissue known as the mesentery. They are connected. The intestine which is there, it has actually this fatty tissue known as the mesentery, which will bring the blood supply to the intestine, which is going to bring the blood supply to the intestine. So the blood supply of this intestine or the blood vessels are coming along with this mesentery itself. What is happening? Definitely the mesentery is fixed. ये mesentery यहाँ पे fixed होती है. Okay, the intestines can move. That is the reason why, as there is a sudden hyperflexion, these intestine move suddenly and there is a tear or there is a rupture of this mesentery. As there is a rupture of mesentery, definitely the blood supply to the intestines can be cut off, and that can even lead to necrosis or wet gangrene of the intestine. But important is, that is a rare feature. But yeah, the most common organ injured during a seat belt trauma, that you have to remember, it is the mesentery. It is nothing but the mesenteric rupture which is going to happen. Seat belt trauma mein, the most common organ injured is the mesentery, and there will be a mesenteric rupture. In blast injuries, if I talk about a bomb blast injury, definitely in a blast injury, definitely all the air-filled cavities are going to be ruptured. So if I talk about the whole body, it will be first of all the eardrum or your tympanic membrane. It is going to undergo rupture. Second will be your trachea, because it contains air, trachea. Third will be your lungs, definitely. Third will be your lungs. Fourth is going to be your stomach. And fifth is definitely going to be your intestine. But if I talk about the blast injuries, only if I talk about abdomen, then the most common organ injured is the intestines. In the abdomen, the most common organ injured during a blast injury is only the intestine. If I talk about the abdomen, okay, abdomen ki agar main baat karu. Next important, if they ask you about the gunshot wound, if they ask you about the gunshot wound, then you have to remember, if there is a gunshot wound to the abdomen, the most common organ injured is actually the small intestine. The most common organ injured is the small intestine, followed by the large intestine, that is your colon. Okay. And last important is if they talk about a deceleration injury. What is a deceleration injury? Here also you are riding a car. Here also you are actually driving a car. But the problem is here there is no seat belt that you have applied. As you have not applied a seat belt, there is a sudden hyperflexion which occurs, and due to that there is actually injury to the DJ flexure. What is the DJ flexure? It is nothing but the duodenojejunal flexure, the site where the duodenum is going to end and the jejunum is going to start. So the most common site of injury in a deceleration injury, okay, suddenly if you decrease the speed, that is definitely going to be your DJ flexure. No issues with this anybody bacho? That is important to be remembered. These are the important one-liners: blunt trauma spleen, penetrating trauma liver, seatbelt trauma mesentery, blast injuries in the abdomen intestine, gunshot wound small intestine, and deceleration injury DJ flexure. Now let's talk about the management of this abdominal trauma patient. If I talk about the management of these abdominal trauma patients, you have to draw this flowchart along with me. We are talking about a case of abdominal trauma management. We are going to talk about a case of abdominal trauma management. Now this abdominal trauma that we know, it can be of two types. Either it can be a blunt abdominal trauma or it can be a penetrating abdominal trauma. First of all, if I talk about the blunt abdominal trauma. And second, definitely it will be the penetrating abdominal trauma. Second is going to be my penetrating abdominal trauma. Okay. These are the two kinds of abdominal trauma. Now, here definitely the patient can be either hemodynamically stable or they will be hemodynamically unstable. What do I mean by this? Hemodynamically stable matlab, okay, we know that hemodynamically stable matlab the patient is not in shock, the patient's BP and the heart rate is normal. As the patient's BP and heart rate is normal, the shock index of this patient will be less than 1. But hemodynamically unstable matlab the patient is going to be in shock. That means his blood pressure is going to fall due to a lot of bleeding and the heart rate is going to rise. Therefore, the patient's shock index will be more than 1. Okay, that is what I mean by hemodynamic stability and instability. Okay, so once you have understood that, so we know that the patient of blunt abdominal trauma can be hemodynamically unstable or that patient can be hemodynamically stable also. Okay, there are both probabilities that definitely our patient can be hemodynamically unstable or the patient can be hemodynamically stable. Same happens with penetrating abdominal trauma. Not all cases of penetrating abdominal trauma will be unstable. Okay, some cases can be stable as well. So there can be a case of penetrating abdominal trauma who is hemodynamically stable, whereas another case of penetrating abdominal trauma will be hemodynamically unstable. We are going to talk about almost all of them. Okay, we are going to talk about almost all of them. Okay, these are the possibilities that we are going to have. Okay, these are the possibilities that we are going to have. It is eardrum, trachea, lungs, stomach, and small intestine. Okay. Next important bache, if I talk about this, let's start with the blunt abdominal trauma unstable patient. Important is in all the patients, whether they are having a unstable, whether they are hemodynamically stable or they are hemodynamically unstable. Important is whether they are having a blunt abdominal trauma or a penetrating abdominal trauma. The first line investigation in all these conditions is going to be a FAST. What is a FAST? I have told you, it is nothing but a focused assessment by sonography in trauma. I'll talk about it later. It is actually a rapid ultrasound which is done in the emergency. And why it is done? It is only done to check any fluid collection, and that fluid in a trauma patient is not going to be any serous fluid, right? It is going to be blood. So we are actually trying to check for any blood collection in the abdominal cavity or around the abdominal cavity in the patient. Okay, so that is important. That is the reason why we are going for a FAST. So the first line investigation, if they ask you in any patient, first line investigation, if they ask you in any patient, it is going to be a FAST. We can even go for an E-FAST. If the patient is hemodynamically unstable, better go for an E-FAST, because we don't know that whether it is only a case of abdominal trauma or it is a case of abdominal plus thoracic trauma. Or thorax ke liye we have to go for an E-FAST, extended fast. Okay? Or we can go for just a fast if the patient is stable. Okay, so fast or E-FAST, whatever it is. The first line investigation will always be this one. The first line investigation is always this one. Okay? Important is now, याद रख लो that if the patient is having, let's talk about the first condition where the patient is hemodynamically, the patient is having a blunt abdominal trauma and the patient is hemodynamically unstable. His BP is falling, the patient is in shock. First line we have done a E-fast. If the E-fast comes out to be positive, if the E-fast comes out to be positive, okay, what do I mean by positive fast? That means the fast is showing us some blood collection. Okay, definitely if the fast comes out to be positive, bache, we have to take up the patient for a surgery. Yes, if the fast comes out to be positive, we have to take up the patient for a surgery, and that surgery, that is nothing else but we are going to open up the abdomen of this patient so that we can look for the bleeding site, and we are going to suture that bleeding particular site. Okay, we are going to repair that bleeding site, right? That surgery, when we are going to open the abdomen to look for a bleeding site, that is called as an exploratory laparotomy. Now otomy is opening, lap matlab abdomen, okay, and exploratory, that means to search for the bleeding site. Therefore the surgery that we are going to do is always an exploratory laparotomy. Okay, exploratory laparotomy should be done in the patient. Okay, याद रखना ये बात. Next important is the condition can be that the patient is hemodynamically unstable. We have done an E-fast, but the fast comes out to be negative. Now in this condition, what has to be done? If the fast comes out to be negative, then don't worry, as the patient is hemodynamically unstable, we are going for resuscitation. Resuscitation patient ka chalu hai. We are giving fluids and everything to the patient at the same time. But here we can repeat a E-fast after 30 to 45 minutes. Yes, if the E-fast comes out to be negative, we can actually go for a repeat E-fast. We can go for a repeat E-fast. How much time later? Usually 30 to 45 minutes later. Reason is, ये जो पहला E-fast था, it cannot pick up anything, any blood collection, because अभी तक इतना blood collect ही नहीं हुआ है. Okay, now when there will be more blood collection, we can easily pick it up on a fast. Therefore now definitely if the E-fast is negative, repeat a E-fast 30 to 45 minutes later. Repeat a E-fast 30 to 45 minutes later. If that repeat E-fast comes out to be positive, if that repeat E-fast comes out to be positive, take up the patient for surgery. Okay, if that repeat E-fast comes out to be positive, take up the patient for the surgery. That is nothing else but exploratory laparotomy. Okay, but if the repeat E-fast comes out to be negative, then so if the repeat E-fast comes out to be negative, then you have to remember, okay, then you have to remember we will go for serial PCV and hemoglobin monitoring. Yes, okay, then we are going to go for, क्यों हम ये कर रहे हैं? Because the patient is unstable बच्चे. That is the reason we are going for it. Okay, here we are going for a serial PCV and a hemoglobin monitoring. Now what is this PCV? PCV is packed cell volume. It is also called as hematocrit. Okay, PCV is nothing but packed cell volume. It is nothing but the hematocrit. Okay, so we are going for serial PCV and hemoglobin monitoring. Every half an hour we are going to send a blood sample of this patient to the lab, and we are actually going to check for the PCV or the hemoglobin of the patient. If the serial PCV and the hemoglobin of the patient is showing us a normal trend, that means it is not decreasing. Okay, if the serial PCV and hemoglobin monitoring is showing us a normal trend, then we can take then we can keep this patient for observation. Then we can actually keep this patient for observation. But if the serial PCV and hemoglobin monitoring, okay, after every half an hour or after every 1 hour, when we send the PCV or the blood sample, and definitely this shows that the hemoglobin or the PCV of this patient is decreasing. If it is showing a decreasing trend, that means there is some bleeding which is occurring. We are not able to pick it up on a fast, but there is some bleeding which is constantly happening, and that is the reason his blood pressure, that is the reason why his hemoglobin and his PCV has been dropping since then. Therefore in this condition bachcho, we have to take up the patient for a surgery. In this condition we have to take up the patient for a surgery, and that surgery is nothing else but a exploratory laparotomy again. Got it? So this is what is done in a patient of blunt abdominal trauma when he is hemodynamically unstable. Got it? Now if I talk about a blunt abdominal trauma patient, but when he is hemodynamically stable हो तो क्या करेंगे? If I talk about the patient of blunt abdominal trauma when the patient is hemodynamically stable, you have to remember first line will be fast. If the fast comes out to be negative, then फालतू में क्यों उठाना पेशेंट को सर्जरी के लिए? Just go for an observation. Just go for an observation in this patient. ठीक है? But if the fast comes out to be positive, in a patient who is hemodynamically stable, then in that condition we have to go for further confirmation. In this patient, we have to go for a further confirmation with the help of a better investigation. And which is a better radiological investigation? It is a CECT, that is a contrast enhanced CT scan. Now why? Because this fast is just a rapid ultrasound. It is not going to confirm anything. So therefore, if we want to see the bleeding site, how much blood has been collected, for all of that, it's better always to go for a CECT, which will give us a detailed it will give us a detailed finding that how many organs have been injured, where they have been injured, how much bleeding is occurring actually. Okay, so for that we are going for a CECT, contrast enhanced CT scan of the abdomen. Please remember that. Contrast, why? Because we have to inject this contrast in the vessel, and by leakage of the contrast from the vessel, we will be able to get how much amount of blood loss is actually happening in the patient. Got it? So therefore, gold standard investigation, okay, gold standard investigation in a patient of any abdominal trauma, when the patient is hemodynamically stable, we are going for a CECT. So you will be like, sir, why we did not go for a CECT when the patient was hemodynamically unstable? Bachche, the CECT is actually a time taking procedure. If we go for CECT abdomen in a patient who is hemodynamically unstable, हम पेशेंट को मशीन के अंदर भेजेंगे तो जिंदा, बट वो बाहर आएगा मरा हुआ. ठीक है? So we do not have enough amount of time in a patient of who is hemodynamically unstable, where we will go for a CECT in this patient. Okay, so that is the reason why CECT is not done in a patient who is hemodynamically unstable. It is only done in a hemodynamically stable patient. And now depending on the findings, definitely we are going to operate the patient. Okay, if the CECT is negative, okay, it is not showing any finding, then definitely we can observe the patient. But if the CECT comes out to be positive, we will go according to the management. Next important, I'll talk about that when I'm talking about splenic and liver trauma. Next important you have to remember is if I talk about the penetrating abdominal trauma. If I talk about a penetrating abdominal trauma, now penetrating abdominal trauma, matlab I have told you stab wounds usually, bullhorn injury for example. Okay, so these are the penetrating abdominal trauma. In that, my patient can be either hemodynamically stable or unstable. Let's first talk about the hemodynamically stable patient. If my patient is having a penetrating abdominal trauma and he is hemodynamically stable, again my first line investigation is going to be fast, focused assessment by sonography in trauma. Here also there will be two possibilities. Either my fast comes out to be positive, and either my fast comes out to be positive or negative. If my fast is negative, then definitely I have to take up the patient for observation. I have to keep the patient for observation. But if my fast comes out to be positive, then definitely I have to go for the gold standard investigation. And what is the gold standard investigation in a hemodynamically stable patient? We know it is CECT abdomen. Okay, it is usually the CECT abdomen. No issues with this, anybody? That is the gold standard investigation. As the patient is hemodynamically stable over here, I can go for a CECT abdomen. And what I'm trying to look on the CECT abdomen now, in a penetrating trauma wale patient mein, I will do a proper evaluation on the CECT. What I'm trying to look for? Actually, I'm trying to look for, as it is a penetrating injury, I'm trying to look for whether the patient's peritoneum has been damaged or not. For example, this is the abdominal wall and this is the peritoneum. I just want to see whether the patient's peritoneum has been damaged or not. Agar peritoneum has been damaged, then definitely there is a very high risk of infection, that is peritonitis, and the patient can die due to peritonitis. So therefore, I have to take up the patient for surgery for sure. But if it is not a case of peritonitis, if the peritoneum is not breached, if the peritoneum is not injured, okay, then I can just go for a local cleaning over there. I can just go for a wound repair locally itself. Okay, I don't need to take the patient for a surgery. So important is here on a CECT abdomen, I have to actually check. For any peritoneal breach. Okay, I have to check for a peritoneal breach definitely. Okay, if peritoneal breach is present, then definitely I have to take up the patient for a surgery. That is nothing else but exploratory laparotomy, because the patient will have a very high risk of peritonitis. Got it? But if the peritoneal breach is absent, in that condition, as the peritoneal breach is absent, in that condition, I will just go for a local wound exploration. I will just go for cleaning of the wound locally. I'll just go for local wound exploration and suturing. Okay, I'll just go for local wound exploration and suturing. Okay, so that's the important thing. No issues with this, anybody? That's important. Now if I talk about a penetrating abdominal trauma wala patient, penetrating abdominal trauma, but he is hemodynamically unstable. That means his BP is constantly falling. Okay? In this patient, if you have E-fast available in your hospital, you can do that. If you have a E-fast available in the emergency, or if you have available in the OT, then you can do that. If it is not available, you can skip this step also. Okay, yaad rakh lo, if the patient is having a penetrating abdominal trauma and he is hemodynamically unstable, you have to remember, if E-fast is available, then you can do it. But E-fast is not available, you can skip this step directly. Yes. And in this patient, you have to always take up whether the E-fast is positive or negative. Irrespective of that, you have to always take up the patient for a surgery that is nothing but exploratory laparotomy. Reason is why we have to always take up the patient for a surgery over here? Because it is a case of penetrating abdominal trauma, and as there is a penetrating abdominal trauma, you have to remember, definitely there can be injury to a lot of vessels, or there can be injury to the peritoneum as well. And as the patient is hemodynamically unstable, that means the patient is having continuous bleeding right now, and therefore his BP is constantly dropping. Okay? So that is the reason why the last condition, we have to always take up the patient for a surgery. Now, if I talk about the conditions, okay, one important condition that we have, I'll write an important statement, okay. In certain conditions, you have to always take up the patient for an exploratory laparotomy, irrespective of the hemodynamic status of the patient. Whether the patient is hemodynamically stable or unstable does not matter. You always have to take up the patient for surgery. And what are these conditions? If a patient is having penetrating abdominal trauma, if penetrating abdominal trauma with any one of the following. अब ये क्या following है? With any one of following. Okay, with any one of following, irrespective of hemodynamic status, irrespective of hemodynamic status, take patient for exploratory laparotomy. Take patient for the exploratory laparotomy. Got it? So what are these conditions when a patient is having penetrating abdominal trauma, and these conditions that we have to take up the patient for surgery? First condition you have to remember, it is evisceration. Now what is this evisceration? But your evisceration, viscera means the internal organs. Evisceration, that means your internal organs are coming out. For example, your intestine is coming out, your omentum is coming out. Can you leave this patient even if he is stable? Can you leave this patient for observation? No, right? So for evisceration, definitely they have given an image previous year, or they have mentioned once that omentum is coming out. So any internal organ or any viscera, when it is coming out, that is an indication of an exploratory laparotomy. Whether the patient is stable or unstable does not matter. Second important, if there is an impaled object. What do I mean by an impaled object? That means patient had a penetrating injury with a knife. Okay, the patient had a penetrating injury with a knife. You cannot remove the knife in the emergency room. Okay, first of all, if there is any layman, okay, if there is any layman जो patient को ले आ रहा है hospital तक, okay, and the patient is actually having a knife inserted in his abdomen, do we recommend the patient, do we recommend the attendants over there to remove the knife? No, we don't. Reason is, never ever try to remove the knife outside the OT. Reason is, if you try to remove the knife, what is going to happen? Maybe that knife or that weapon was pressing a blood vessel. Maybe that knife or the weapon was there. It was actually compressing a vessel. It was having a tamponading effect. You have removed it, and now there will be more bleeding in the patient, and the patient will die even before taking him up to the OT. That is the reason, never ever try to remove an impaled object or a weapon in the emergency room or outside. Always try to remove it under controlled conditions in the OT, because in OT immediately you can operate the patient. That's the reason. Okay? So impaled object has to always removed in OT, whether the patient is stable or unstable, does not matter. Third important condition is bleeding from natural orifice. Yes, if the patient is having any bleeding from oral cavity or from the anal canal, definitely that means there is a constant bleeding which is occurring. So bleeding from natural orifice. Okay, bleeding from natural orifices. Okay. Fourth, definitely you have to remember a patient of peritonitis. If the patient is showing any signs of peritonitis, bache, you have to take up the patient for a surgery, because if you do not clean the peritoneum, it is going to cause shock in the patient and the patient is going to die. Yes, peritonitis can lead to sepsis and shock, and therefore you cannot leave the patient as it is. You have to clean the peritoneum. Peritoneum does not accept any kind of nuisance. No, even if minor infection occurs, the patient is going to die due to that. Okay, so peritonitis is an important one. And last, write it as plus minus soda, because Bailey does not say all patients of gunshot wound, but definitely the protocols say that all patients of gunshot wound, whether they are stable or unstable, they should be taken up for a exploratory laparotomy. Okay, so Bailey had just now changed it, then the recent edition, not the previous ones. So please remember gunshot wound. So these are the 5 conditions. Out of this, any one condition, if it is present along with the penetrating abdominal trauma, irrespective where your patient is hemodynamically stable or he is unstable, you always have to take up the patient for an exploratory laparotomy, that is surgery. Got it? So 5 conditions. First is evisceration, when abdominal organs are coming out. Second is the impaled object, if the knife or the weapon is there inside the abdomen still. Third, bleeding from natural orifices. Fourth, definitely. Okay. Fourth, if there is any peritonitis in the patient. And fifth, definitely if there is any gunshot wound in the patient. Got it? So that is the important thing that you have to be aware of. Got it? Chalo. Now that was about your abdominal trauma. Have you understood this flow chart? This is very important, guys. Try to draw it once. एक बार पढ़ो और उसके बाद है ना खुद draw करने की कोशिश करो. It will be easier. That is how you remember things. Okay. Now if I talk about fast बच्चे, if I talk about fast, definitely fast is nothing but a rapid ultrasound which is done in a case of trauma in an emergency. It usually takes 2 to 4 minutes only. Yes. We do not spend a lot of time on this ultrasound. It is a very rapid ultrasound done inside the emergency room or inside the operation theater if it is available. It will only take 2 to 4 minutes, because we are not going to screen or we are not going to look for the whole abdomen. We are only going to look for blood collection at 4 important sites. That's it. Fast का full form पूछा जा चुका है in a previous year examination. What is FAST? It is nothing but focused assessment. It is nothing but focused assessment by sonography in trauma. It is nothing but focused assessment by sonography in trauma. Okay. Focused, that means we are not going to look for all the sites in the abdomen. We are going to look for only particular sites in the abdomen where there are chances of blood collection. Okay. Assessment is nothing but examination or evaluation with the help of what? Sonography, that is the ultrasound in a patient of trauma. That is what is FAST. Okay. Now, as I've told you, I'm going to keep the ultrasound probe at 4 important sites itself. And what are these 4 important sites? For example, okay, for example, if this is your abdomen, definitely this is how you have to remember it. This is how you have to remember it. ठीक है, जब भी fast लिखोगे, always write a fast like this, so it becomes easier to remember. Always write a fast like this, then it becomes easier to remember. ठीक है, so these are the 4 sites, and why I'm writing it in this manner, because it will always be in this particular sequence itself. Yes, first time you have to keep the probe in the subxiphoid space below the xiphisternum. Why? Because you want to look for any blood collection around the heart, that means in the pericardial cavity, to rule out what? To rule out cardiac tamponade. Second site is this one. You have to keep the probe in the right hypochondrium to look out for any blood collection around the liver, that is in the perihepatic region. Which pouch is there? Hepatorenal pouch, the pouch between the kidney and the liver. Hepatorenal pouch, or we can even call it as the Morrison's pouch. The third site is over here. You have to keep the ultrasound probe in the left hypochondrium to look for any blood collection around the spleen, that is the perisplenic region. Here it will be blood collection in the splenorenal pouch, SRP. Okay? Why? Because liver and spleen, we know they are the most commonly injured organs in a case of blunt or a penetrating abdominal trauma, and they will cause maximum bleeding. And last is the 4th one, down here, that means in the pelvis. The 4th one is actually a pelvic pass, where you will keep the ultrasound probe in the suprapubic region, and it is to look for any blood collection in the pelvis, because if there is any blood bleeding inside the abdomen, due to gravity, all that blood is going to go inside the pelvis, and it is going to collect in the pouch of Douglas or the Cul-de sac. Got it? So that's the important thing. So this is 2nd, this is 3rd, and this is 4th. So let's write down the 4 passes which are there in a patient of FAST. The first pass which is there, as I've told you, this one will be a pericardiac pass. This one will be a pericardiac pass. Okay, it is kept, the ultrasound probe is kept in the subxiphoid region. The ultrasound probe is kept is actually in the subxiphoid space. And why? As I've told you, to rule out cardiac tamponade. Next pass which is there, bacho, you have to remember, it is actually the perihepatic pass. The second is the perihepatic pass, where you have to keep the ultrasound probe in the right hypochondrium. You have to keep the probe in the right hypochondrium, and it is to look for any blood collection where in the hepatorenal pouch. HRP is nothing but the hepatorenal pouch, or we can even call it as a Morrison's pouch. We can even call it as a Morrison's pouch. No issues with this. Next important, the third pass which is there is known as the perisplenic pass. The third pass which is there is known as the perisplenic pass. It is for it here the ultrasound probe which is there, it is kept in the left hypochondrium, and it is to look for any collection in the splenorenal pouch. It is to look for any collection in the splenorenal pouch. And the last one, fourth one, we know it is the pelvic pass. In the pelvic pass, definitely here the ultrasound probe which is there, it is usually kept in the suprapubic region. It is usually kept in the suprapubic region, okay, to look for any collection in the pouch of Douglas. To look for any collection in the pouch of Douglas, or we can say the cul-de-sac. Got it, bacho? These are the important things that you have to remember. These are the 4 sites of your fast: focus, assessment by sonography, and trauma. Okay. Now, what is an E-fast or extended fast? Now, what is an E-fast or extended fast? So, E is nothing but a extended fast, bache. Okay, E is nothing but extended fast, definitely. Now, ये extended fast है क्या bala? Along with the 4 conventional fasts, along with the 4 conventional passes we check in a case of fast, 2 more are added over here. Okay, the 2 more which are added, bacho, the 2 more which are added, definitely. Okay, these 2 extra which are added, they are for the right and the left thoracic cavity, to look for any blood collection in the right and the left thoracic cavity. Why? Because we want to rule out hemothorax if there is any blood collection in the pleural cavity of this patient. Okay, so this second and the other 2 passes which are added, these are for the right and the left thorax, or for the thoracic cavity. These are for the right and the left thorax or the thoracic cavity. When we say that the fast is positive, हमने यही देखा ना कि fast positive, fast negative. When we say that the fast is positive, so if there is more than 100 cc, see, some books say 200, but usually most of them say 100. So if there is more than 100 cc, if there is more than 100 cc of collection, that collection, I'm not sure if it is blood, but majority of the times after a case of trauma it will be blood. So if there is more than 100 cc of blood, please remember, peritoneal cavity does not contain any fluid. Yes, in a normal male, peritoneal cavity contains 0 ml of fluid, and in a normal female also it contains 0 ml of fluid, but around the menses, definitely in the mid cycle, it can contain around 5 to 10 ml of fluid maximum, not 100. Okay, so please remember, more than 100 cc of collection is okay, more than 100 cc of collection inside the abdomen is what is considered as a positive fast. It is what is considered as a positive fast. Okay, so that is important. This has been a question as well. Now, for example, in a particular condition or a particular hospital where fast is not available, then what has to be done? And this has been a previous year question also, because please remember, पहले तो fast नहीं था, तो क्या होता था? When fast was not available, बच्चे, then we used to go for a invasive technique. Okay, invasive because we used to use needle over there, and that was called as DPL, diagnostic peritoneal lavage. So if fast is not available in earlier days, now it is not done commonly. Yeah? Now it is not done because fast is available everywhere almost. Okay, diagnostic peritoneal lavage was done. Diagnostic peritoneal lavage mein what we used to do? We used to actually take a syringe. Okay, we used to actually take a syringe with a needle, and we used to insert it below the umbilicus. We used to insert it below the umbilicus till the peritoneal cavity, and we used to tried to aspirate some blood. Okay, we tried to aspirate some blood. If there was more than 10 cc of blood which used to come, okay, if more than 10 cc of blood used to come inside the syringe, if there was more than 10 cc of aspirated blood in the syringe, then definitely we used to take up the patient directly for a surgery, that is exploratory laparotomy, because that was suggestive that the patient is having a lot of bleeding. But if there was not more than 10 cc of blood, then in that condition, definitely what we used to do was, we used to make an incision. We used to make an incision below the umbilicus. That is called as an infra-umbilical incision. And via that incision, we used to insert a catheter. उस incision के through हम क्या डालते थे? Catheter. And via the catheter, we used to give 1 liter of normal saline. Yes, via the catheter, we used to actually pour 1 liter of normal saline into his abdominal or into his peritoneal cavity. And then we used to aspirate all this fluid. वापस से निकाल देते थे इस fluid को. Okay, we used to aspirate this fluid, And when you used to remove that fluid, some amount of that fluid was sent to the pathology lab. Some amount of that fluid was sent to the pathology lab. Over there, this fluid was examined under the microscope, and the pathologist used to tell us if there is more than 1 lakh RBCs or more than 10,000 WBCs, okay, that was considered as a positive diagnostic peritoneal lavage. And if that was present, again, that means there was a bleeding in the patient, and in that condition also we used to take up the patient for a surgery. ठीक है, अभी इतना डीप में जाने की जरूरत नहीं, because this is not commonly done. You can just remember diagnostic peritoneal lavage is positive if more than 10 cc of frank blood can be aspirated. Okay, more than 10 cc of frank blood is aspirated. That is suggestive of a positive diagnostic peritoneal lavage. And as I've told you, agar wo nahi hota, definitely we give 1 liter of normal saline, then we aspirate the fluid, send it to the pathology lab. If definitely the AST level is more than 150, the AST level is more than 75, sorry, if AST level is more than 75 in that fluid, okay, in definitely the RBC is more than 1 lakh cells. So in all these criteria are met, then we used to call it as a positive DPL. So leave that, just remember this one, because any which ways it is not going to appear in the exam, because we don't commonly do it. Okay? That is important. No issues with this. Have you understood, bache? Okay. PUD is nothing but pouch of Douglas, HRP and SRP are hepatorenal and splenorenal pouch. Thank you so much. Okay. No issues with this. FAST is nothing but a focused assessment by sonography in trauma. It is a rapid ultrasound which is done for 2 to 4 minutes. There are 4 passes for it: pericardiac, perihepatic, perisplenic and pelvic pass. Okay, pericardiac pass is to rule out any cardiac tamponade in the patient, perihepatic to rule out any blood collection around the liver, perisplenic to rule out any blood collection around the spleen, and pelvic to rule out any blood collection in the pelvic cavity or inside the pouch of Douglas. Okay, that is important. Chalo. Now if I talk about splenic trauma, bachcho, important is in a case of splenic trauma, important is we know that spleen is the most common organ injured in a case of blunt abdominal trauma. And there will be a lot of bleeding from this organ because it is a parenchymatous organ. Okay? Splenic trauma mein the patient can have classical 2 signs. What are these? The first one is known as a Coher sign. Questions have been asked on these signs. Okay? The first one is known as a Coher sign. What is a Coher sign basically? So you have to remember, if there is blood collection around the spleen, that means around in the left hypochondrium. Definitely blood collection in the left hypochondrium is constantly going to irritate the left dome of the diaphragm. And we know if the left dome of diaphragm is irritated, we know that diaphragm is supplied by which nerve? Diaphragm is supplied by the phrenic nerve. Root value being C3, C4, C5. So as the diaphragm is irritated, these phrenic nerve or this root value C3, C4 and C5 are irritated as well. We know that these same root values are also going to supply the shoulder tip. And that is the reason why the patient is going to have a left shoulder tip pain. The patient is definitely having pain in the left hypochondrium because definitely there is injury to the spleen over here. But the patient will also have a referred pain to the left shoulder tip as well. That is what is called as a Coher sign, which is classically suggestive of a splenic injury. This is a common sign which is seen. Okay? So please remember, in a patient of splenic injury, Coher sign is seen, which is nothing but referred pain to the right to the left shoulder tip. Referred pain to the left shoulder tip. Okay, why it is so? As I've told you, due to irritation of diaphragm. Okay, it is nothing but due to irritation of left diaphragm or left dome of diaphragm, whatever you call it. Okay, so that's important. That is what is your splenic sign, Coher sign. Next important which is seen is known as the balancer sign. What is the balancer sign now? Just understand it. Balancer sign mein kya hota? See, for example, if it is a case of ascites. Okay, ascites is also a fluid, definitely fluid collection in the peritoneal cavity or the abdominal cavity is known as ascites. So in a patient of ascites also there will be dullness on percussion. जब हम percussion करेंगे, if there is fluid collection in the abdomen, there will be dullness. And even if there is blood collection in the abdomen, that will also cause dullness. Now, how do we differentiate whether the patient is having ascites or the patient is having actually splenic trauma, which is causing blood collection? So for that reason, you have to actually percuss the patient. Okay, you have to percuss the abdomen of the patient, and you have to see. Okay, for example, see, you have to percuss the abdomen of this patient, and we have to see. Okay, you have to percuss the abdomen of the patient, and we have to see where the dullness is actually coming. Then we have to ask the patient to shift on one side. As the patient shifts on one side, definitely all that fluid, if it is a case of ascites, all that fluid is going to collect on this side. Now definitely the dullness will not come over here. Pehle the dullness was coming over here, but now the dullness will not come over here. The dullness will be moved over here. Okay, that means this is what is called as a shifting dullness. But if it is a case of a hematoma, bache, if it is a case of blood collection around the spleen, okay, even if the patient changes the position, the dullness will be at the same site. The dullness will be at the same site because it is due to a hematoma formation, not due to some ascites. That is important thing. So please remember, balances sign बच्चे, balances sign की अगर मैं बात करूं, you have to remember the balances sign which is there here. It is nothing but absence of shifting dullness. It is nothing but absence of shifting dullness. मतलब dullness shift नहीं होता है. Okay, it remains at the same side. It is nothing but absence of shifting dullness. ठीक है? So that's the important thing. Now important is how do we manage a case of splenic trauma. बस इतना ही याद रखना तुम्हें कि कहाँ पे सर्जिकल, कहाँ पे कंजर्वेटिव मैनेजमेंट करते हैं. You don't need to remember the grades. You just have to remember the management according to the grade. Okay, so grade याद रखने की जरूरत नहीं है. I'm just like doing it once, then you don't have to remember it. Okay, first of all, if I talk about the grades of splenic injury, there are 5 grades of splenic injury. So type 1 जो होता है splenic injury or the grade 1 splenic injury बच्चे, here definitely there is either a hematoma which covers less than 10% of the surface area, or there is a laceration which is less than 1 centimeter deep. Laceration which is less than 1 centimeter deep. Then grade 2 splenic injury. In grade 2 splenic injury mein there is a hematoma which is 10 to 50% of the surface area, or there is a laceration which is 1 to 3 centimeters deep. Laceration which is 1 to 3 centimeters deep. Third important is the splenic injury where there is a hematoma which covers more than 50% of the surface area, or there is a laceration which is more than 3 centimeters deep. Then definitely the grade 4 splenic injury. Here you have to remember that there is actually injury to the main vessels or to the hilar vessels as well. As there is injury to the main vessels of the spleen which are supplying the spleen does not receive blood supply now, and therefore there is devascularization of spleen. Devascularization matlab the spleen is not receiving enough blood supply. And how much percent of spleen? More than 25% of spleen. There is devascularization in more than 25% of spleen. That is grade 4 splenic trauma. Grade 5 splenic trauma mein you have to remember, grade 5 splenic trauma mein, grade 5 splenic trauma, here there is a laceration which is causing completely shattered spleen. Okay, due to that there is a complete damage to the spleen. Spleen mein kuch bacha hi nahi, kachra chura chura ho gaya uska. Okay, so grade 5 there is a completely shattered spleen, or there is injury to the main vessel like the splenic artery to the splenic vein. Okay, the main vessel which is supplying the spleen has been injured. Okay, so vascular injury to the main vessels of the spleen, that leads to complete devascularization of spleen. The spleen is not receiving any blood supply now due to that. Okay, so these are the grades of splenic injury. As I've told you, मैंने एक बार explain कर दिया बस. That's the important thing. Now you don't have to again understand it. You just have to remember the management of the patient. Okay, how are we going to manage the patient? If it is a case of splenic trauma, bache, if it is a case of splenic trauma, then you have to remember in a patient of splenic trauma how we are going to manage the patient. In a patient of splenic trauma, you have to see whether the patient is if the patient is unstable or stable. If the patient is unstable or stable. If the patient is hemodynamically stable, then definitely we have to do what? We have to do a fast in the patient. And when the fast comes out to be positive, definitely. If the fast comes out to be negative, तो कोई दिक्कत ही नहीं है. If the fast comes out to be negative, just send the patient for observation. If the fast comes out to be negative, just send for the patient for observation. But if the fast comes out to be positive, in that condition definitely the gold standard investigation should be done, which is CECT abdomen. The gold standard investigation should be done, which is a CECT abdomen, and depending on that definitely we are going to manage the patient. How? Let's see that. पहले उसके पहले unstable patient का देखते हैं. Unstable patient में तो it's very easy. If the patient is having if the patient is having low BP, that means the patient is hemodynamically unstable. We are going to go for a fast. If the fast comes out to be positive, immediately we are going to take up the patient for a surgery, that is the exploratory laparotomy. Immediately we are going to take up the patient for a surgery, that is exploratory laparotomy. No issues with this, anybody? That's important. Now definitely in a patient who is hemodynamically stable, we have done a fast. If the fast is negative, observation. Fast is positive, go for the CECT abdomen. Now on CECT abdomen we have to see whether the patient is having grade 1, 2, 3, 4 or 5 injury. If the patient is having grade 4 or 5 injury, if the patient is having grade 4 or 5 injury, can we manage the patient by observation? No. We have to take up the patient for a surgery. So here we will take up the patient for a surgery directly. Yes. And what is that surgery? We already know the surgery is nothing else but exploratory laparotomy has to be done. Exploratory lap. Plus we have to, can we save the spleen? In grade 4 there was more than 25% devascularization of spleen, and in grade 5 there was a completely shattered spleen. Can we save the spleen now? No, there are no chances to save the spleen. It's better to remove the spleen. So therefore in these conditions we go for an exploratory lap plus splenectomy. Yes, we don't keep the spleen over there, we have to remove the spleen. Okay, plus splenectomy has to be done. No issues with this. If it is a grade 3 injury, I'll talk about that. If it is a grade 3 injury now, I'll talk about that. पहले grade 1 and 2 की बात करूँ. If it is a grade 2 injury, grade 1 or a grade 2 injury, if it is a grade 1 or a grade 2 injury, what are we going to do? In a grade 1 or a grade 2 injury, the patient mostly will be stable. Okay, the patient is mostly stable. So here just we can go for an observation. We can just do the basic resuscitation of the patient. We can give blood transfusion to the patient, whatever is required. But here we can just go for observation of the patient. Yes, just for observation. In grade 3, definitely you have to remember, in grade 3, here we can go for angioembolization. Whichever vessel is bleeding, we can try to block that vessel first. So in grade 3 injury, we can go for an angioembolization. Yes, we can go for an angioembolization. You have to remember, we can block the bleeding vessel. And if angioembolization fails, then we have to take up the patient for a surgery. If that angioembolization fails, then we usually take up the patient for a surgery, that is exploratory laparotomy. One important thing I would like to tell you, in grade 4 and grade 5, the surgery will always be splenectomy. We have to remove the spleen. We cannot save the spleen. But in grade 1, 2 and 3, but in grade 1, 2 or 3, definitely we can try to repair the spleen. And we can try to repair the spleen with the help of sutures. And that surgery which is there, where we repair the spleen with the help of sutures, is known as splenography. So definitely splenography can be tried in grade 1, 2 or 3 splenic trauma. अगर grade 1, 2 or 3 splenic trauma है बच्चों, in definitely that condition, hematoma it is balances sign, hematoma. Abscess में भी देख सकता है. Okay, abscess में भी देख सकता है, but mainly it is hematoma, because abscess अगर fix हो जाता तो ही देख सकता है, otherwise abscess में भी shifting dullness दिखेगा. Got it? This is the important thing बच्चों. Splenic trauma, unstable patient, fast positive, take up the patient for surgery. Splenic trauma, stable patient, fast negative, go for observation. Fast positive, go for the gold standard investigation, that is CECT abdomen. On CECT, assess which kind of which grade of splenic injury the patient is having, and depending on that, decide the management of the patient. If it is grade 4 or 5, take up the patient for surgery, that is exploratory laparotomy plus splenectomy. If it is grade 1 and 2, just go for an observation, if required surgery only. Grade 3, angioembolization is the first step that we do. If it fails, then take up the patient for a surgery. कोई दिक्कत यहाँ पर? Okay. Now let's talk about the liver trauma. Just like this, we are going to talk about the liver trauma, बच्चे. Okay. If I talk about the liver trauma, we know that liver is the most common organ injured in a case of penetrating abdominal trauma. In a case of liver trauma, there was a recent question in this time. Pringles manure का इस बार भी question था. This is a question which is repeated twice or thrice in the exam. ठीक है? So there are classical 4 P's in a patient of liver trauma. What are these 4 P's? First of all, we try to push. What is push? Definitely, we try to apply pressure. For example, the patient is having liver trauma and there's a lot of bleeding which is occurring. So the first thing we try to do always is push, or we try to apply pressure at the bleeding site. Okay, for that definitely we are going to open the abdomen. ये सब abdomen open करके काम चल रहा है. So first of all, we try to push, or we try to apply pressure at the bleeding site. If that does not help, we will try to do Pringles manure. And what is this Pringles manure? Sequence is same, okay? जो मैं sequence बता रहा हूँ, it will be the same sequence which will be followed. Pringles manure will be done. Okay, I'll talk about Pringles manure क्या होता है. So Pringles manure में actually we compress the hepatoduodenal ligament. What does this hepatoduodenal ligament contain? This hepatoduodenal ligament, बच्चे, it contains actually the main blood vessels which supply the liver. And what are the main blood vessels which take blood to the liver? 80% of the blood supply of liver comes from the portal vein, and 20% of the liver blood supply comes from the hepatic artery. So definitely both these vessels are present inside the hepatoduodenal ligament, and therefore in a case of Pringles manure, we try to clamp, we try to press this hepatoduodenal ligament. And if definitely after compressing the hepatoduodenal ligament, if the blood decreases, if the bleeding decreases, that means definitely the source of bleeding was either the portal vein or it was the hepatic artery. Okay, that is the Pringles manure. Okay, next important is if this also does not work. After this, definitely we are going for plugging. Okay, we actually go for plug. We actually try to clamp the bleeding vessel, whichever is there. And if this also does not work, in that condition, we have to go for finally pack. What is packing? Definitely here we have to put a lot of gauge pieces above and below the liver. पूरे liver को pack कर देना with a lot of gauge pieces above and below the liver. We have to completely pack the liver so that there will be a lot of compression on the liver and the bleeding will decrease. Okay? So these are the 4 P's of liver trauma, बच्चे. That is, first is push, that is apply pressure. Second is Pringles manure. Third is plug, and fourth is pack. Okay? Now important is what is the Pringles manure. As I've told you, I'll be talking about that. So Pringles manure, लिख लो एक बार. Pringles manure, it is nothing but compression of Pringles manure is nothing but compression of hepatoduodenal ligament, compression of hepatoduodenal ligament. Where exactly? At the foramen of Winslow. Okay, at the foramen of Winslow. So this site has been asked. Just remember this. कहाँ पे compress करते हो? You actually try to compress it at the foramen of Winslow. ठीक है? Hepatoduodenal ligament is compressed at the foramen of Winslow. Now, usually we know that this contains hepatoduodenal ligament contains portal vein and hepatic artery. So therefore, after this manure, if bleeding decreases, after this manure, if the bleeding decreases, okay, definitely the source of bleeding is what? It is either the portal vein or it is the hepatic artery. The source of bleeding is either the portal vein or it is the hepatic artery. Important is you have to remember, if the source of bleeding is the portal vein, you have to go for a repair. Yes, if the source of bleeding is a portal vein, you have to go for a repair. But if the source of bleeding is hepatic artery, you can just go for a ligation. You will be like, why sir? Important is portal vein carries 80% of the blood supply. You cannot ligate it completely. Okay, so therefore if portal vein is injured, you can go for a repair, but hepatic artery, when just go for a ligation, it is only 20% of the blood supply, which can be compensated by the portal vein. But in case if the bleeding does not stop, if the bleeding does not decrease, if the bleeding does not decrease, that means the source is neither the portal vein nor the hepatic artery. यहाँ पे the source is either the hepatic vein or the inferior vena cava. यहाँ पे the source is actually the hepatic vein or the inferior vena cava, and then you have to go for the management according to this. Okay, then you have to go for the management according to the injury which is present. Sorry, according to the injury which is present. No issues with this, anybody, bachcho? That is important to be remembered. Okay, no issues with this. Hopefully that's fine. Okay. Now let's talk about the liver trauma and the management according to the grades. यहाँ बहुत easy है. Again, you don't have to remember the grade, but just for once I am talking about the grades. बाद में भले ही भूल जाओ, does not matter. Most important is to remember the management according to the grade. Nobody is going to ask you the grade. ठीक है? Now, if I talk about the grade 1 of liver injury, यहाँ पे there are 6 grades of liver trauma. So grade 1 of liver injury, it is same. 1, 2 and 3 are same as spleen. Grade 1 of liver injury, it is less than 10% of a hematoma. Okay, grade 1 liver injury is less than 10% subcapsular hematoma involving the surface area, or it can be a laceration which is less than 1 centimeter deep. Okay? Grade 2 liver injury which is there, bacho, here there is a 10 to 50% of a hematoma which involves, here actually there is a hematoma which involves 10 to 50% of the surface area, or there is a laceration which is 1 to 3 centimeters deep. Next important, it is a grade 3 liver injury. Grade 3 liver injury mein you have to remember, there is a hematoma which covers more than 50% of the surface area, or there is a laceration which is more than 3 centimeters deep. Okay, these are three same as spleen. Now the difference will be grade 4 now. Grade 4 liver injury which is there, here it is usually 25 to 50% of the lobes are not receiving blood supply. Yes. Okay, 25 to 50% lobes which are there, they have been injured, they have been lacerated, they have been damaged. Okay, that is what is called as grade 4 liver injury. Grade 5 liver injury mein more than 50% lobes of the liver have been damaged. More than 50% lobes of the liver have been damaged. That is a grade 5 liver injury. Or the main veins like the hepatic veins have been damaged. And finally grade 5 in finally in grade 6. In grade 6 liver injury, there is a hepatic avulsion. What do I mean by hepatic avulsion? There is a complete loss of blood supply to the liver. Yes, there is completely shattered spleen था ना वहाँ पे, यहाँ पे completely shattered liver होगा. There is complete loss of damage. There is complete loss of blood supply to the liver. Now, depending on these liver injury, let's talk about the management of the patient. If I talk about a liver trauma, if I talk about a patient of liver trauma, it's easy if the patient is hemodynamically unstable. If the patient is hemodynamically unstable, definitely the fast of that patient should be done. And if the fast comes out to be positive, if the fast of the patient comes out to be positive, take up the patient immediately for a surgery. That is nothing else but exploratory laparotomy. Take up the patient for exploratory laparotomy immediately for a surgery. But if I talk about the liver trauma where the patient is hemodynamically stable, then you have to go for a fast. Then you have to go for a fast of this patient. If the fast comes out to be negative, you can just go for an observation. If the fast comes out to be negative, you can just go for an observation. But if the fast comes out to be positive, okay, it is a stable patient. If the fast comes out to be positive, it is a stable patient, then definitely we can go for a CECT. Then we can go for a CECT abdomen of this patient. And once we do a CECT abdomen, we have to assess the grade of the patient, and depending on the grade, we have to do the management of the patient. On CECT abdomen, you have to see whether it is a grade 1, 2 or a 3 liver injury. If it is a grade 1, 2 or 3 liver injury, the management of the patient is just observation. The management of the patient is going to be just observation. But if it is a grade 3, 4 or if it is a grade 4, 5 or 6 liver injury, if it is a grade 4, 5 or 6 liver injury, you have to take up the patient for a surgery, that is exploratory laparotomy. You have to take up the patient for a surgery, that is exploratory laparotomy. Easy है ना ये, इसमें तो कोई दिक्कत नहीं है. So definitely liver trauma, if the patient is unstable, go for a fast comes out to be positive, take up the patient for a surgery. If the patient is stable after a liver trauma, do a fast. If fast is definitely negative, go for observation. But if fast is positive, as this is a stable patient, you can go for a CECT abdomen, assess the liver injury, in which grade it is. If it is grade 1, 2 or 3, go for observation. Grade 4, 5 and 6, go for surgery. That's it. No issues with this, bachche? These are the important things that you have to remember. Okay? Now let's talk about the retroperitoneal trauma. Shall I? Now let's talk about the retroperitoneal trauma. Okay? Hepatic artery it is, HA. No issues with this, anybody? Now let's talk about the retroperitoneal trauma. Now retroperitoneum, that means behind the peritoneum. Which are the organs which are present in the retroperitoneum? Mainly it is the kidneys which are present in the retroperitoneum. Mainly it is your major vessels like your aorta and the inferior vena cava which are present in the retroperitoneum. Therefore, if there is a retroperitoneal trauma, there will be risk of injury to these major vessels of your body and definitely to the kidneys as well. Therefore, it is important, and this has been asked twice in the examination. Yes, in the recent NEET PG also there was a question on retroperitoneal trauma, and August 2020 FMG also there was a question. Okay? यहाँ पे easy है, you just have to tell that which kind of management. Do we go for a conservative or surgical exploration? That's it. Okay? If I talk about retroperitoneal trauma, बच्चों, in retroperitoneal trauma, the retroperitoneum, first of all, you have to understand, just like neck, it is also divided into 3 zones. The 3 zones of the retroperitoneum which are there. The first zone we can see, it is the central zone. And what lies in the central zone? It is the main vessels like your aorta or your inferior vena cava. Okay? Next is definitely the zone 2. In zone 2, definitely it is the lateral zone, as you can see. And what lies in the lateral zone? As you can see, it is the kidneys mainly and the renal vessels over here. It is the kidneys and the renal vessels over here. Okay? Then third important is the zone 3. That is zone 3 is nothing but the pelvis. And in the pelvis, as you can see, definitely it is the important pelvic organs. But apart from that, it is the major iliac vessels as well. It is the major iliac vessels because these are the direct branches of your aorta, common iliac vessels, right? That's important. Now, can anybody tell me, out of these 3 retroperitoneal zones, in injury to which of the zones will always require a surgical exploration? It cannot be managed conservatively. Please tell me, कौन से zone में अगर injury है तो we always go for a surgical exploration? Please tell me this. Basic logic पे based question, जल्दी से बताओ. Very good. Very good, very good, very good. And this has been a question previous year. यही तो question था previous year. Okay, so that is the important thing. You have to remember definitely, if one zone which always and always requires a surgical exploration, बच्चे, it is definitely zone 1 because it contains the major vessels. यहाँ पे definitely the bleeding would not stop without a surgical exploration. ठीक है? So let's write down zone 1 which is there. It is nothing but the central zone. And this central zone of the zone 1, it contains the major vessels like your abdominal aorta and your inferior vena cava. Okay, if I talk about the zone 2 is nothing but the lateral zone, and in this lateral zone we have the important organs like the kidneys and the renal vessels. We have the important organs like the kidneys or the renal vessels. Okay, next definitely is the zone 3. In zone 3 which is there, it is nothing but the pelvic zone, and in the pelvic zone definitely we are going to have the iliac vessels. We are going to have the iliac vessels and the pelvic organs, something like the uterus, the bladder. Okay, we are going to have the pelvic organs. Important is, if I talk about management of this patient, if I talk about the management of retroperitoneal zone, as I've told you, zone 1 which is there, zone 1, whether the patient is stable or unstable, zone 1 के patient में it's better to always go for a surgical exploration. Zone 1 always needs surgical exploration. Always needs surgical exploration. ठीक है? Why? Because there are major vessels inside the zone 1. ठीक है? Always need surgical exploration, that has to be remembered. Next important, if I talk about zone 2 and zone 3. If I talk about zone 2 and zone 3, definitely in these patients you have to remember, if it is a hemodynamically stable patient, it's better that we can first of all fast तो करेंगे, definitely fast पे ज़्यादा कुछ दिखेगा नहीं. CCT will do, on that CCT definitely will get some changes, or we can get some blood collection over here. And then definitely we will go for angioembolization in this patient first. Yes, we are going to first of all try angioembolization. And if that angioembolization fails, अगर ये fail हो जाता है, if that angioembolization fails, then we can go for a surgical exploration. Then we can go for a surgical exploration. ठीक है? So that is what is done for zone 2 and zone 3. Angioembolization first. If that fails, then go for a surgical exploration. Important is, बच्चों, you have to remember that in a previous year August examination, okay, अब तक क्या पूछा गया था? Which zone needs surgical exploration always? And the answer was easy, it was zone 1 always. But in August examination there was a question, August 2020 FMG, there was a question that which among the following zones will require surgical exploration? And options were zone 1 and zone 2, zone 2 and zone 3, zone 1 and zone 3, all of the above. What is your answer in that condition, बच्चे? What is your answer in that condition? अगर दो zones choose करने हो तो? Anybody? No, it is the zone 1 and the zone 3. Okay, it is the zone 1 and the zone 3. The basic reason being, please remember, in zone 3 there are direct branches of the abdominal aorta. There are direct branches of these abdominal aorta known as your common iliac vessels, and these common iliac vessels are larger branches than the renal vessels. Renal vessels तो छोटी छोटी है ना. So that is the important thing. Therefore, if you have to choose two zones definitely, then your answer should be zone 1 and zone 3. Okay, so please remember, अगर zone 2 choose करने हो for surgical exploration, then your answer can be zone 1 and zone 3. ठीक है? Because zone 3 also contains major vessels like the iliac vessels. ठीक है? So that is the reason. यहाँ पे अगर दो zones choose करने हो, only if the question is there, only if the question is like that. Options में और कोई है ही नहीं, single option. Okay, so that is what is zone 1 and zone 3. ठीक है? Now last topic from your abdominal trauma. Okay, the first of all answer the question as I've told you. ये question का answer क्या, जल्दी से बता दो. What is the answer for this question, बच्चे? 17-year-old girl presents to the ED with a stab wound. Stab wound, as I've told you, it is nothing but a penetrating trauma to the abdomen of this patient. Okay, and her BP is falling 80 by 50 millimeters of mercury. Pulse rate is 120 beats per minute. If I calculate the shock index of this patient, okay, the heart rate of the patient is 120 and the BP of the patient is only 80. So definitely the shock index is more than 1. If the shock index is more than 1, we know that the patient is hemodynamically unstable. And if the patient is hemodynamically unstable with a penetrating abdominal trauma, what should be done in this patient? What should be done in this patient? Very good. If we have EFAST available in the option, if we have EFAST, ये देखो, a lot of sites now, you are going to get it as कि directly surgery. See, surgery will be done, बट द इंपॉर्टेंट सर्जरी तो हमेशा ही करनी है इस पेशेंट में, बिकॉज इट इज अ केस ऑफ पेनिट्रेटिंग abdominal trauma and the patient is hemodynamically unstable. Surgery is always done, always, इसमें कोई ऑप्शन ही नहीं है. Okay, but important is if we have e-fast available in the hospital, are we going to do the e-fast? Yes, because it takes 2 minutes for doing the e-fast. Now it's better because we are going to get better information कि कहाँ पे bleed हो रहा है, कहाँ पे नहीं हो रहा, where is actually the site of bleeding. So if e-fast is available, we can do it. If e-fast is not available, then तो obviously choice नहीं है. But in the option as e-fast is there, that means wherever they are talking about, किसी भी hospital के बारे में बात कर रहे हैं, they are actually talking about a hospital or a tertiary care center where e-fast is available. That is the reason we can go for an e-fast first, and then if that e-fast would not have been in the option, I would have gone for exploratory laparotomy as my answer. Okay, got it? That is the basic logic behind it. Okay, no issues with this. It's NSAID. NSAID का अगला question है बेटा. This is the question of NSAID. This is the question of NSAID. A 60-year-old male, known case of coronary artery disease. He is actually taking a lot of NSAIDs. He was brought to the emergency with acute pain abdomen. Okay, in emergency with acute pain abdomen. On examination, tenderness. What is tenderness? Pain on touching. Tenderness was present all over the abdomen. मतलब diffuse tenderness है, पूरे abdomen में कहीं भी आता हुआ पेशेंट चिल्ला उठता है दर्द के मारे. ठीक है. There is guarding. What is guarding बच्चे? Whenever we try to palpate the abdomen of this patient, due to pain, what the patient is going to do? The patient is trying to contract his abdominal muscle. As the patient contracts his abdominal muscle, will he be able to palpate the patient? No. So that is the reason patient को बहुत दर्द होता है, therefore वो तुम्हें palpate नहीं करने देता. तो वो palpate नहीं कैसे नहीं करने देता? He tries to contract his abdominal muscle. He tries to make the abdomen hard, so you cannot palpate further. That is what is guarding. Got it? The BP of the patient is falling. It is around 90 by 60 millimeters of mercury. The chest X-ray has been given. They are talking about a condition related to the abdomen, and they are giving a chest X-ray. This is the first hint for you that they are actually talking about a perforation. ठीक है, वो सबसे इंपॉर्टेंट हिंट होती है. अब तक पूरा abdomen के बारे में चल रहा था, अचानक chest X-ray क्यों दिया गया? That is the first hint that they are most likely talking about the perforation. What is the preferred management in this patient? ठीक है. So now let's deal with a very common question of your exam, and that is what is perforation peritonitis or a hollow viscous perforation. ठीक है. I would have discussed it in peptic ulcer disease also, but I want to discuss it over here in trauma itself. ठीक है. Important is if I talk about hollow viscous perforation, hollow viscous is nothing but an empty organ. जिस भी organ में cavity हो, something like a stomach, intestine, all of these are hollow viscous. Hollow viscous is a viscous organ or a visceral organ which is hollow or empty from inside. So hollow viscous perforation. Now what are the causes of this hollow viscous perforation, बच्चे? There are multiple causes of perforation in the in abdominal organs. Now there can be perforation of the stomach or there can be perforation of the intestine over here. Hollow viscous perforation का मतलब either there is perforation of the stomach or there is perforation of the intestine. That intestine can also be a small intestine or a large intestine. ठीक है? Important is what are the causes? First important cause is definitely NSAIDs, a lot of NSAIDs. If a patient is eating a lot of NSAIDs, what is going to happen? What are NSAIDs? Non-steroidal anti-inflammatory drugs. Something like naproxen, okay, something like combiflam, something like, for example, paracetamol, all of these, okay, indomethacin. All of these are your NSAIDs definitely. And if you eat a lot of NSAIDs, what is going to happen? Definitely NSAIDs are known to cause erosive gastritis. What do I mean by erosive gastritis? Gastritis is definitely inflammation of the stomach. Erosive matlab they are going to cause damage to the stomach wall. Yes, there will be ulcer formation on the stomach wall. And as this ulcer keeps on increasing, there will be a point where this wall is going to perforate, when this wall is going to rupture, right? That is what is called as a hollow viscous perforation, बच्चे. ठीक है? So if a patient keeps on taking a lot of NSAIDs, that too on a regular basis, so important is the patient will develop an erosive gastritis, due to which the patient develops an ulcer. Ulcer thin out होता रहेगा and the wall is going to perforate finally. ठीक है? Second is a patient of peptic ulcer disease. We know already in a patient of peptic ulcer disease, one of the complications, if there is an ulcer, again the same funda applies. The wall will keep on becoming thinner and thinner and thinner. Okay, the wall will keep on becoming thinner and thinner and thinner, and finally it is going to perforate. Okay, that is important. Or it can be due to trauma as well. Yes, perforation is not always due to gastritis. Perforation can also even occur due to trauma. Okay, it can even occur due to trauma as well. No issues with this, anybody? Or it can even be due to a penetrating injury to the abdomen. Okay? So any kind of trauma, as I've told you. Now, when there is perforation, all the contents of your intestine, they are going to leak out into the peritoneal cavity. Important is your peritoneal cavity is a no nonsense or a no nonsense cavity or a very sterile cavity. It does not handle any kind of nonsense. That means if these contents are going to leak out into the peritoneum, all the peritoneum is going to be inflamed. Pura peritoneum inflame ho jayega, and due to that the patient develops peritonitis. Now what are the signs of peritonitis due to this perforation? So whenever a patient comes to you with peritonitis, bache, these are the hints, these are the keywords for your question. Okay, peritonitis ka case aata hai. So therefore you have to remember the patient is going to first of all have nausea and vomiting. Okay, the patient can have nausea and vomiting. Second, the patient will have severe abdominal pain. The patient can have severe abdominal pain. Okay, and definitely when we try to palpate the abdomen of this patient, almost everywhere in his abdomen he is going to have tenderness. Kahin bhi touch karo, patient chilla uthega dard ke mare. Okay, everywhere the patient is going to have tenderness. Okay, on examination there will be diffuse tenderness. On examination there will be diffuse tenderness, that is tenderness all over the abdomen. Okay. Second important, the patient is also going to have cardboard like rigidity. Okay, the patient is also going to have cardboard like rigidity in the abdomen. If you try to palpate the abdomen now, the patient is going to have a cardboard like rigidity because the muscles will undergo spasm. As I've told you, the patient will not let you palpate the abdomen. He will try to contract his abdominal muscle, that is called as guarding. Okay, that is called as guarding. Okay, and definitely the patient can have tachycardia. The patient initially can have tachycardia. As it is an infection and an inflammation, the patient can even have a low grade fever. The patient can even have a low grade fever. Okay, and important, finally the patient will land up into, finally the patient can land up into shock as well. Tachycardia to hai hi, BP bhi drop hona shuru ho jayega. The patient can finally land up into shock as well. Got it? So that's the important thing. So these are the features of your peritonitis, bache: nausea, vomiting, severe abdominal pain, diffuse tenderness, cardboard like rigidity, guarding, tachycardia, low grade fever and shock. Okay? Important is, now definitely if it is a case of hollow viscous perforation, the patient comes to you with peritonitis, what is the first line investigation? So if I talk about the first line investigation in a patient who comes to me with features of peritonitis, my first line investigation is going to be send the patient for an X-ray. My patient will be sent for an X-ray. X-ray chest plus an X-ray abdomen. Yes, I'll get both the X-rays done. Reason is, on X-ray abdomen, I'll get to know about the extent of peritonitis and if there is any kind of intestinal obstruction. And secondly, X-ray chest, because I want to see this classical sign. Now definitely intestines, usually intestine contain gas, and that gas is nothing but air. So when the intestines are going to perforate or the stomach is going to perforate, this gas or this air is going to go inside the peritoneal cavity and it will collect beneath the dome of the diaphragm. As it collects beneath the dome of the diaphragm, you can see air appears black on X-ray. Can you see here normally on below the dome of diaphragm? Can you see anything black? No. But here below the dome of diaphragm, you are able to see this blackish appearance. It is actually due to the collection of air. This is nothing but the gas or the air which has collected below the diaphragm. This is called as the gas under diaphragm. Important is left side pe bharosa zyada mat karna, because on left sides bacche, sometimes it can be the stomach bubble which can be there. Okay, so you have to be aware of that. It cannot always be the gas under diaphragm in a case of on the left side of the chest X-ray. Right side pe agar hai, to it is sure shot diagnosis of gas under diaphragm. Okay, so that's the important thing. So you have to remember this is a classical gas under diaphragm which is seen. Okay, and important is this gas under diaphragm which is there. Can it does it look like mustache? Okay, मूंछों जैसा लग रहा है ना दोनों तरफ. Definitely that is what is known as the mustache sign, or we can even call it as the cupula sign. So gas under diaphragm on a radiograph or an X-ray is known as a cupula sign or a mustache sign. It is known as a cupula sign or a mustache sign. No issues with this, anybody, bache? So this is the cupula or the mustache sign. Okay, which is seen classically in this patient. Okay, gas under diaphragm, cupula or the mustache sign which is seen in the patient. कोई दिक्कत नहीं है इसमें. And if it is a small neonate, if it is a small child who is having perforation peritonitis, or there is a hollow viscous perforation, can you see there is collection of air over here below the diaphragm? There is collection of air between the liver and below the abdominal wall. Okay, so below the peritoneum and actually below the between the abdominal wall and between the liver, there is again air collection which is there, or gas collection. Okay, therefore can you see the abdomen of this child or abdomen of this neonate? Does it appear like a football? Yes, it appears like a football. That is the reason why this is classically known as the football sign. This is classically known as the football sign. So please remember बच्चों that you have to remember key, if there is perforation in a patient on the X-ray, you will classically get either the gas under diaphragm known as the cupola or moustache sign or football sign. Why it is so? Because the gas escapes outside the peritoneum and there is collection of gas in the peritoneum. What is collection of gas called as? It is called as pneumoperitoneum. So both of these are actually signs of pneumoperitoneum. Okay, both of these are actually signs of pneumoperitoneum. When any kind of gas or air collects inside the peritoneal cavity, okay, and that is usually seen in a case of perforation. That is usually seen in a case of perforation. कोई दिक्कत नहीं है इसमें. This is a very सरकारी question of your examiner's favorite question. हाँ बहुत बार repeat हुआ है. इस बार नहीं था, but otherwise it has been repeated a multiple number of times. In even in Jan exam it has been repeated. Treatment की अगर मैं बात करूं, what is done for treatment in the patient? Definitely I've told you that peritonitis is an indication of direct surgery. Yes. अगर पेशेंट में पेरिटोनाइटिस है, वी हैव टू गो फॉर अ सर्जरी. ओके, एक्सप्लोरेटरी लैप्रोटोमी. सो डेफिनेटली वी हैव टू फर्स्ट ऑफ ऑल, फर्स्ट लाइन मैनेजमेंट अगर पूछे तो बेसिक रिससिटेशन हैज टू बी डन. ओके, फर्स्ट लाइन मैनेजमेंट इज बेसिक रिससिटेशन. इंपॉर्टेंट इज यू विल से सर आफ्टर एक्सरे चेस्ट और abdomen, if the x-ray chest or abdomen is inconclusive, can we go for a CT? Yes, if the patient is stable, we can even go for a CECT abdomen. If the patient is stable, if the patient is stable, we can even go for a CECT abdomen. The same funda applies over here. Okay? Important is basic resuscitation, but only use a water soluble contrast, because if you use a water insoluble contrast, that is rather causing damage to the peritoneum then. Okay? Next is basic resuscitation. If I talk about, in this basic resuscitation, you have to remember, after this is the first line management, why tumhara A, B, C, D, E should be done. Okay, you have to give IV fluids and all to the patient. After this, definitely we will go for the definitive management. And what is the definitive management? It is nothing but exploratory laparotomy. It is exploratory laparotomy. And then when we open up the abdomen, we are going to clean all the abdomen. And cleaning the peritoneal cavity is what is called as, anybody, cleaning the peritoneal cavity is what is called as lavage. We are going to send a lot of saline. We are going to actually pour a lot of saline in the abdominal or peritoneal cavity, and we are going to clean it out. That is what is called as a lavage. So therefore, we are going for an exploratory laparotomy plus a peritoneal lavage. Okay, we are going for an exploratory laparotomy plus a peritoneal lavage. You have to remember this. Important is, now once we have done this exploratory lap plus peritoneal lavage, then what is to be done further? What has to be done further? Okay, what has to be done further, bache? So you have to remember, after this, definitely, if the patient presents to you early, okay, if the patient has presented to you early, that means within 24 to 48 hours of the symptom onset. अगर 24 से 48 घंटे के अंदर अंदर आता है patient, if the patient was presented to you early within 24 to 48 hours of perforation, that means there was minimal contamination, right? That means there was not much contamination, there was a minimal contamination which was there, right? And if there was minimal contamination, okay, if there was minimal contamination, can we go for a repair immediately? Yes, because if there is less infection, the sutures will hold each other. If there is a lot of infection, then the sutures are not going to hold each other, the sutures will come off. Here definitely, as there is minimal contamination, we can go for immediate repair, and we have to actually repair this perforation. So what are we going to place over here? We are going to place over here a omental patch. Omentum का एक patch लगा देंगे. What is omentum? Omentum is the policeman of your abdomen. Yes, it is the lymphoid tissue of the abdomen which fights the infection in the abdominal or the peritoneal cavity. So उस abdomen के लेके we are going to patch it over the intestine. ठीक है? This is known as a Graham's patch. So you have to remember, minimal contamination अगर होगा तो we can go for a omental patch or a Graham's patch repair. Omental or a Graham's patch repair. No issues with this. But if you have to remember, if the patient presents to you, after 24 to 48 hours, if the patient presents to you after 24 to 48 hours, and if there is a lot of contamination, if there is a gross contamination, बच्चे बहुत ज़्यादा गंदा हो चुका है, if there is a gross contamination, can you repair it immediately? No, we cannot repair it immediately. In that condition, we just leave a drain over there for some time. We leave a drain. Till that time, when there is a drain now, we cannot give anything orally to the patient. Okay. In that time, you have to give IV fluids to the patient. You have to remember that. And till the infection subsides, because we are giving IV antibiotics also to the patient. So therefore the infection is going to subside or it is going to decrease. So once the infection decreases, then we can go for a repair. But now, as of now, we are only going to leave a drain. We are only going to leave a drain. ठीक है, and then repair later on. कोई दिक्कत नहीं है बच्चे इसमें. That has to be remembered. Explorative laparotomy plus peritoneal lavage within 24 to 48 hours. Minimal contamination. Go for an immediate Omentel or a Graham's patch repair. But if the patient presents to you after 24 to 48 hours, then gross contamination, just leave a drain as of now and go for the repair after some time. ठीक है, so that's the important thing. Congenital hypertrophic pyloric stenosis, it usually does not show football sign. Football sign is usually seen in this pneumoperitoneum ka cases. It can be seen in pediatrics. You might have heard about pneumoperitoneum. CHPS में usually it is not the football sign, it is the other signs which are seen. ठीक है, target sign देख सकती है on ultrasound definitely. Single bubble sign is seen on X-ray. And on barium meal definitely you will see the shoulder sign, you will see the mushroom sign, you will see the string sign. Now let's discuss about thermal injuries. Burns छोटा सा topic है. So once we are done with burns, then we can call off the session. Important is it will keep on going otherwise. So I thought actually to complete general surgery today, so that tomorrow onwards we'll start with endocrinal, vascular or GIT, like that. Okay, that's the problem. The funda is actually, I thought to complete it today. Okay, so no issues. Okay, no issues. Chalo, ठीक है. Thermal injuries or burns I'll be completing tomorrow. Actually, we were planning to complete your ENT also before time, like before I go, because I have to leave for classes again. So yeah, before 15th or no, before 17th rather, before 18th or 17th, we were thinking about completion of ENT. But let's see. We'll complete surgery definitely. ENT maybe will start just. So let's see that. ठीक है, ठीक है. Tomorrow you don't have a surgery class, sorry. Surgery class will be day after tomorrow. Tomorrow I'm not sure. शायद holiday होगा, or whatever class you have, you can enjoy. But please do revise surgery then. ठीक है, जितना हुआ है, at least try to revise surgery once. Shall we call off the session then? ठीक है. Hopefully you have enjoyed the class, you have understood the class. Okay, more important definitely. ठीक है. That is more important कि तुम्हें समझ में आया या नहीं. ठीक है, चलो. Try to understand surgery, it will become much interesting. Okay, you have a test tomorrow. Okay, no issues with that. Chalo then. Study for the test. Answer please. What have you asked? I missed your question. Dekh bhi nahi raha. Annotated notes I'll share. Don't worry about that. What question have you asked? You can ask it tomorrow, or you can ask it again, or you can reach out to me personally as well. पूछो तो सही. I cannot find your question. There are many messages over here ना. अच्छा, okay, this question, sorry. अच्छा, ऐसा बोलो. So 60-year-old male, known case of CAD, NSAIDs ले रहा था, brought to the emergency with acute pain abdomen. On examination definitely tenderness was present all over the abdomen. Guarding थी, BP 90/60 था. Chest X-ray showing gas under diaphragm, copula या mustache sign. Preferred management. Now we know it is a case of hollow viscous perforation. कभी कभी बस diagnosis पूछा जाता है. So you can just answer this one. ठीक है, जब diagnosis पूछा जाए. Whereas यहाँ पे they have asked you about the management. So option सबसे पहले option D says observation and conservative management. Can we do that? No, because it is a case of peritonitis and the patient is hemodynamically unstable. We cannot go for only observation and conservative management. Ultrasound abdomen is not required in this condition. That's the important thing you have to remember, because it is a classical case of peritonitis. Okay. Ultrasound abdomen is not required. If they would have said fast, I would have thought about it. दोनों में difference है बच्चे. Ultrasound abdomen is a complete thing about it, complete examination of the abdomen. Fast is only a rapid ultrasound. ठीक है? So that's important. No issues with this. Anybody? Next is option A and B. B says emergency laparoscopic repair. Do we do laparoscopic repair in any case who is a hemodynamically unstable? No. Laparoscopic surgeries are contraindicated in patients who are hemodynamically unstable. First thing. Second thing, laparoscopy will not help us to repair the perforation properly or even do a peritoneal lavage. That is the reason we don't go for a laparoscopic repair. So answer has to be option A. IV fluids doge, stabilize the patient, basic resuscitation, which is the first line management, and then definitive is exploratory laparotomy along with the peritoneal lavage. Got your answer? Thank you so much. Let's meet in the next. ठीक है?